everyone. My name is Elaine Liang, and I'm a second-year medical student at the Kaiser Permanente Bernard J. Tyson School of Medicine in Pasadena, California. It is an absolute honor to serve as this year's Master of Ceremonies and to welcome you all to the the fourth International Journal of Medical Students World Conference of Medical Student Research 2025. This year, we received over 120 submissions from medical students across the globe. After a thorough review, 50 abstracts were selected for presentation. These works reflect the dedication, creativity, and passion of students committed to advancing medical science and improving patient care. This year, we are excited to host a two-day conference, expanded from the traditional one-day format to allow even more students the opportunity to share and disseminate their research. Day one will feature our oral presentation sessions, and day two will include both oral and poster presentations. We will also be announcing this year's award recipients at the conclusion of day two, so we encourage you to join us then to celebrate the results and the culmination of our students' hard work. As many of us know firsthand, conducting research as a medical student is not easy. The process is filled with challenges, steep learning curves, and moments of uncertainty. Since its founding in 2009, the International Journal of Medical Students has been dedicated to supporting student researchers from around the world by creating a platform that fosters collaboration, mentorship, and scholarly growth. We believe that by building a global community where medical students can connect, share their experiences, and learn from one another, we can empower the next generation of global medical professionals to navigate the complexities of medical research and find inspiration along the way. Today's conference brings together medical students and judges from around the world, united by a shared commitment to scientific inquiry and innovation. Before we begin our program, I would like to acknowledge the tremendous effort behind this event. To the Abstract Review Committee, the conference organizing team, our judges, reviewers, and every individual who helped bring this conference from concept to reality, thank you so much for your very hard work and dedication. Now, without further ado, it is my pleasure to welcome Dr. Francisco J. Bonilla-Escobar, Chief Editor of the International Journal of Medical Students, to deliver his opening remarks. Welcome, Dr. Bonilla-Escobar.
Good morning. Thank you, Elaine, for the kind words. Good morning, everyone. It is my great honor to welcome you to the fourth annual World Conference of Medical Student Research, WCMSR, proudly organized by the International Journal of Medical Students, IJMS. Today, we gather with participants from around the world to celebrate the work, talent, and the scientific curiosity of early career researchers. The IJMS was founded in 2009 with a clear mission: to be the leading platform for medical student research. As an open access peer-reviewed journal, we publish original clinical, translational, public health, and basic science research conducted by medical students and recently graduated physicians. With a rigorous two-step double-mask peer review process, we ensure the highest methodological and ethical standards while fostering a new generation of editors and peer reviewers trained through the Web of Science Academy and the Committee on Publications Ethics COPE resources. Today, IJMS represents authors from around the globe, receives hundreds of submissions every year, and maintains a 20% acceptance rate. Last year alone, our website reached nearly 300,000 visits across more than 190 countries. Importantly, we uphold a diamond open access model. This means that it is free for authors and free for readers, affirming our belief that access to scientific knowledge should never be a barrier. This year, World Conference of Medical Students Research marks an important milestone. What began as a one-day event has now grown into a two-day international conference, reflecting the steady increase in submissions, the expanding diversity of participating countries, and the remarkable productivity of medical student researchers worldwide. Day one features full podium presentations showcasing original research across medical and health sciences, and day two is dedicated to poster presentation, allowing an even broader range of students to share their work. The growth of this conference underscores a central truth. Medical student research is essential for the future of medicine. Early involvement in research shapes clinicians who think critically, innovate responsibly, and understand firsthand the importance of evidence in improving patient care. The energy, creativity, and intellectual rigor that students bring to research accelerate discovery and strengthen our scientific community. I would like to express my sincere appreciation to the organizing committee, whose dedication makes this global event possible. Our director, Chloe Carrington, our abstract managers, Markarius Murkere, Sahil Arail, Alex Mwangi, Moses Stefanos, and Sohil Arail. Our director of logistics, Hannah Kabil, and our master of ceremonies, Elaine Liang. And to all presenters, judges, mentors, or student editors who serve as this conference peer reviewers, our public relations and communications team, led by Mihail Gabriel Said, and attendees joining us from every corner of the world, thank you for supporting the mission of the IJMS and for believing in the power of early career research. I wish you 2 inspiring days of science, collaboration, and connection. Welcome to the 2025 WCMSR.
Thank you, Dr. Bonilla-Escobar, for your inspiring words. I would now like to invite Chloe Carrington, director of this year's conference, to share her opening remarks. Welcome, Chloe.
Thank you, Elaine. Good day, everyone, and welcome to the International Journal of Medical Students' 4th Annual World Conference of Medical Student Research. I am Chloe Carrington, a second-year medical student at the University of Queensland-Ochsner, and your director of the conference. This conference is a celebration of the curiosity, resilience, and innovation that global medical students from over 25 countries brings to the future of healthcare. Over the next 2 days, we'll hear research that challenges assumptions, opens new doors, and reminds us that discovery is at the heart of medicine. To our 50 presenters, congratulations, you were selected out of 128 highly competitive abstract submissions. Balancing the demands of medical school with the rigor of research is no small feat, and your commitment shines through in the work that you'll share. You've proven that the next generation of physicians is not only clinically skilled, but also scientifically driven. I also wanted to personally thank the judges, my conference team, the IJMS student editors, and other journal members who are responsible for the marketing, logistics, and assessment of every single abstract submitted. Your hard work and care is what made it possible to celebrate our presenters and their wonderful research. So let's set the tone. This is a space for bold questions, lively discussion, and genuine celebration of each other's achievements. Let's cheer loudly, engage fully, and make these days a highlight of our journey in medicine. Presenters, it's your time to shine. When it's your turn to present, turn on your mics and cameras to share your research on this global stage. You'll be sharing your screen, so have your slides and posters ready. Judges, please ask a question after each presentation and consider the thoughtful responses that you receive from the presenters. Audience, please vote for your favorite presenters by scanning the QR code and filling out your ballot. With that, let's begin. Here's to discovery, collaboration, and the future of healthcare.
Thank you, Chloe, for your thoughtful remarks. And now it is my pleasure to begin our first session by welcoming our 2 judges, Dr. Arkadeep Dali, an academic clinical fellow of gastroenterology from the Sheffield Teaching Hospitals at the NHS Foundation Trust and the University of Sheffield, and Dr. Samuel Dyer, MD, PhD, and CEO Chairman of the Board of the Medical Science Liaison Society. Without further ado, we will also be proceeding with our first session of oral presentations for the day. Our first presenter is Dr. Madhuri Dommaraju from India, who will be presenting their abstract entitled Ease of Nasogastric Intubation Using a Frozen Nasogastric Tube by a novice intern in anesthetized intubated adult patients, a randomized controlled parallel assignment study. Dr. Madhuri, please go ahead and share your screen to begin your presentation.
Yeah. Good morning, everyone. I'm Dr. Dommaraju, and I just finished my residency in anesthesiology last year, and I'm working in the Department of Anesthesiology and Critical Care in Sri Venkateswara Institute of Medical Sciences, Tirupati, India. And today I'm presenting my original article, The Ease of Nasogastric Intubation Using a Frozen Nasogastric Tube by a Novice Intern in Anesthetized Intubated and Adult Patient, a randomized open-label parallel assignment study. Nasogastric intubation often poses a challenge, especially in anesthetized intubated patients with a high failure rate of almost 55% in the first attempt with conventional method of insertion. It could be due to the presence of multiple apertures in the distal portion, making it susceptible to kinking, coiling, and knotting. To improve the success rate of nasogastric intubation, many innovative methods, including the frozen nasogastric tube, have come into use, though none is proved to be the best. Most of the times, the first responder to nasogastric tube insertion is a novice medical trainee, so we wanted to study the success rate of frozen nasogastric intubation by a novice intern. Our main aims of the study was to determine the success rate of nasogastric intubation using a frozen nasogastric tube, and then compare the same with room temperature nasogastric tube in adult human participants with tracheal tube in situ by novice interns. Our primary objectives were to determine and compare the first attempt success rate using a Woods test, and to determine and compare overall success rate using a plain chest X-ray. Our secondary objectives were to determine and compare the duration of insertion with both the techniques, and also to document the incidence of complications such as coiling, kinking, and bleeding. Before starting the study, we have got regulatory approval from Institute Ethics Committee, as well as got registered in Clinical Trial Registry of India. We have included all adult patients aged more than 18 years with endotracheal tube in situ, and we have excluded patients with obvious nasal deformity who had contraindications for nasogastric tube insertion, patients who have refused to participate in our study and who did not require chest X-ray post-operatively, as well as pregnant women. Our study was conducted over a period of 1 year, and it is a prospective randomized open label parallel assignment study. We have conducted the study after randomization using computer-generated random number, and got allocation concealment using sealed opaque envelope technique. We have selected 200 patients, in which 100 patients received frozen nasogastric tube, that is tube which was frozen for 2 to 4 hours before the procedure, and control nasogastric tube group who have received room temperature nasogastric tubes. Based on the previous study, which demonstrated a 55% first attempt success rate with conventional nasogastric insertion technique, a 20% improvement in the first attempt success rate was considered as meaningful clinical difference. The required sample size with equal allocation to achieve 80% power was estimated to be 94 per group. Further, considering a dropout rate of 5%, we enrolled 100 patients per group. Both the nostrils were prepared with nasal decongestion before the procedure. A standard 16-French nasogastric tube was passed as per random group allocation and using standard technique of insertion after smearing a lubricant jelly and without any external manipulation or instrumentation. All the procedures were performed by doctors in training with no direct experience in inserting the nasogastric tube. The statistical tests which were applied was descriptive statistics, student unpaired t-test, and square test. A p-value of less than 0.05 was considered statistically significant, and the analysis was done using the statistical package for social sciences version 20. The demographic variables were seen comparable between both the groups. Coming to the primary objectives, the comparison of first attempt success rate was seen higher to be in the frozen nasogastric tube, and it was statistically significant. Overall success rate was also seen higher to be in frozen nasogastric tube, and it was statistically significant. The mean duration of procedure was higher in the control group with statistical significance. The occurrence of complications was seen higher in control group, which was statistically significant. Coming to complications, patients, coiling was also seen to be higher in control group, and it was statistically significant. The bleeding was comparable in both the groups, whereas kinking was seen to be higher in control group, but it was not statistically significant. A recently conducted meta-analysis involving 17 randomized controlled trials observed that use of modern techniques of nasogastric tube insertion, such as the reverse Selick maneuver, neck flexion with lateral pressure, frozen nasogastric tube, resulted in a better chance of success and a high overall insertion success rates as compared to the conventional technique. Among the various methods, we decided to select frozen nasogastric tube for the study as it is cost-effective, resource-friendly, simple, and can be used in patients with cervical injury. The frozen nasogastric tube was selected over waterfall frozen group because it is less time consuming for confirmation and it has lower risk of contamination and also lesser chance of mucosal injury and bleeding. Our main strength of the study was that it was the largest study as for pertaining to the frozen nasogastric tube, and we have also used gold standard method for confirmation of nasogastric tube position, that is chest x-ray. The limitation of our study was that we did not focus on long-term complications such as sinusitis, epistaxis, and nose erosion, and we cannot also extrapolate this study details to pediatric population as well as adult conscious patients. Coming to the conclusion, frozen nasogastric tube ensures a smooth passage of nasogastric tube with high overall success rate and minimal complications when nasogastric intubation is entrusted to a trainee candidate. Therefore, the results of a study can be offered as a starting point to further improvise the skill of the trainee while using a frozen nasogastric tube as a first-line device for nasogastric intubation. Thank you.
Thank you for that excellent presentation, Dr. Maduri. We will now open the floor for questions. I'd also like to welcome our judges, and Dr. Dyer, to share their comments or questions as well.
Yeah, who's going first? Should I go first? I didn't know what the order was.
Yeah, you're welcome to go first.
Yeah. I guess my question, great presentation. Thank you for that. Very interesting research. You know, when I think about these frozen nasogastric tubes, evidence in other research has shown that there is improved success when we think about in an expert's hands. And I always like looking at this research and sort of thinking about this from the perspective of who cares? Why are we doing it? What is different about it? And so when I think about that, and you had some compelling data, I guess the question really is fundamentally, how does demonstrating their effectiveness with, as you pointed out, novice interns offer some sort of unique contribution to current clinical or medical standards?
So it's rather than commenting about the medical standard, it's more of a starting point, like because the like in India, like interns are the first people who respond to whatever case first comes into the hospital. So demonstrating that use of a frozen nasogastric tube by them leads to a better success rate, even for a relatively newer trainee, enforces that that use of frozen nasogastric tube is a better way to be used in case of interns rather than a normal nasogastric tube and trying multiple times, which also underputs their confidence as they're entering into the hospital doing the procedures for the first time.
Yeah, excellent. Yeah, and I guess just my follow-up question, just one more here, and I'll let the others jump in as well. Was there any sort of efforts in the study or in the planning of the trial to evaluate the learning curve over time of the interns?
We didn't further evaluate because the study involved like doing the procedure by interns who didn't have prior exposure. So we have selected the interns who were coming into our department soon after their undergraduation. So they didn't have exposure. They didn't put nasogastric tube. They didn't put more than 10. So those were the graduates we selected to try the frozen nasogastric tube insertion. Maybe the further collection of data, because it was done over 1 year and they're at the end of their internship period. So maybe written pro forma, like asking about their evaluation of their improved skill can be useful, but it was not done till now.
Okay, excellent. Thank you.
Thank you. In the interest of time, I'm going to have one comment from all the judges as well. So please go ahead.
Hi, Dr. Dommaraju, it's a really nice presentation. I just have one question. In your abstract, you have mentioned that the kink rate was 5:1 in the frozen group compared to the non-frozen one. Can you explain how that is possible?
I'm sorry, the kinking was higher in the not frozen one.
Okay, I think in the abstract you mentioned otherwise. Okay, in that case, can I ask a follow-up question?
Yeah,
So
sure.
this was quite a controlled environment in the ITU where you had prepped the patient, you have used nasal decongestant, but that's not a regular practice in when you put in a ward or ED setting. What do you think is the practical feasibility of this thing to be implemented in an ED or a ward setting?
Yeah, so that was one thing which I have put in the discussion, that we did it in the ICU as well as operation theater, where we have paralyzed the patient and intubated the patient. So one thing is, it's difficult in those patients because there is a lot of resistance because of the relaxity of the tissues, but it is a rather different kind of technical issues when the patient is conscious and when he is not cooperative, especially in the emergency setups. So we cannot extrapolate this study to that. And also in what I see when I practiced my internship is when the patient is awake, it's kind of easy when he's cooperative, because swallowing allows nasogastric tube into the direction of the esophagus, whereas when he is paralyzed because of the soft tissue relaxity, it's much more difficult. That's why we have chosen frozen tube to be done in the paralyzed patients.
Thank you so much.
Thank you.
Okay, thank you very much for your presentation. I enjoyed it. I had a little issue because of how quickly you had moved the slide, which described the demographics of the groups. And Dr. Dyer did ask a question, but I'm not so sure on the variability among your students. What was that? How was that? I mean, how did you ensure that the experience between the groups that were using frozen versus the control was good?
So we have selected the interns who didn't put nasogastric tubes more than 10 in number. So those were the students who involved in the study in putting the tube.
Okay, so that's how you control for that variability. Yeah. All right, thank you so much.
Thank you so much, Dr. Gossel-Williams. So yeah, now we will be moving on to audience voting. So we will display a QR code for audience voting, viewing. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards that we will announce during tomorrow's ceremony, so please don't forget to participate. And judges, please also go ahead and fill out your scoring sheet for the presentation as well. All right, thank you so much. Now we will be moving on to our next presenter. We'll be moving on to our next presenter. So I'd like to welcome Mrs. Ariba Khan from Pakistan, who will be presenting her original research on assessing the precision of AI-generated medical answers and evaluation of Llama 3-powered meta AI. Hi, Mrs. Khan. So go ahead and share your screen whenever you're ready.
Can you all hear me?
Yes, we can hear you.
Oh, all right. Thank you so much.
We can't see your screen though.
Yeah, I'm sharing. Yeah.
Okay.
Can you see it now?
Wonderful. Go ahead.
All right. Good morning, everyone. I am Ariba Khan, a final year medical student from Liaquat National Hospital and Medical College, Karachi, Pakistan. And today it's a pleasure for me to present my study titled Assessing the Precision of AI-Generated Medical Answers and Evaluation of Llama 3-Powered Meta AI. These are the contributing authors. And here is a brief overview of today's presentation. All right, let's begin with the background. We all know that AI is rapidly becoming an important tool in medical education. Large language models use advanced training methods to understand and generate human-like medical text, making them useful in medical learning. Meta AI, that is powered by Llama 3 model, was introduced in Pakistan in 2024 and is accessible through various social media platforms without any additional login or subscription required. And because of this easy availability, it has been frequently used by medical students to clarify medical questions. However, unlike ChatGPT or other AI models, there is little to no research data available that actually assess the accuracy of this particular model in medical education. So our research had two main objectives. First, to assess the correctness of meta AI generated answers to medical questions, and second, to assess the reproducibility of the results. And for this purpose, we employed an evaluation-based research design. So we structured a questionnaire that consisted of a total of 240 questions, that is 30 questions from each of the 8 basic sciences subjects. We then put that questionnaire into the AI model. We collected the responses, compared the accuracy of those responses with the existing resources, and finally, we analyzed the results using descriptive and inferential statistics. For the purpose of analysis, we also categorized the questions into two broad categories. That is category A, that consisted of case-based questions that consisted of real-life scenarios, and that were total 108 in quantity. And the second category was category B, containing the fact-based questions, which consisted of total 132 questions. Secondly, for standardization of input and to ensure consistency, all the questions were entered into the Meta AI engine by the same author, following the command to be specific and incorporate any applicable medical guidelines to the chatbot. The reproducibility assessment was done by re-evaluating the Meta AI for previously failed questions 14 days after the initial analysis. The analysis of finding was done by comparing the AI-generated responses with the validated key provided in the resources, and the accuracies were re-evaluated using the IBM version 27. Ethical considerations were not applicable as no human and animal level data were used in our study. Moving on to the results, as we have discussed, we conducted two analyses, the initial and the rescored analysis. In the initial analysis, all the 240 questions were entered into the AI tool, and out of those, 187 were answered correctly, leading to a mean accuracy of 77.9%. If you talk about categorical analysis, Meta AI performed better with the case-based questions, with an average accuracy of category A being 82.4%, and that of category B being only 74.2%. Meta AI performed better with pathology, in which only 1 out of the 30 questions were answered incorrectly in the initial analysis, and the minimum accuracy was in forensic medicine. When we re-evaluate the Meta AI after 14 days of the initial analysis, in which the previously failed 53 questions were entered into the AI model, this time only 12 of them were answered correctly, leading to a mean accuracy of only 22.6%. If we talk about categorical analysis, once again, Meta AI performed better with the clinical based questions, with an average accuracy of category A being 47.3% and that of category B being only 8.8%. The maximum accuracy in rescored analysis was in microbiology and the minimum in pathology. Moving further, figure 2 illustrates the categorical analysis. We have been talking about meta-AI performed better with category A, that were clinical-based questions in both initial and rescored analysis. The figure 3 illustrates the subject-wise analysis. We can see that meta-AI performed better with biochemistry, microbiology, pathology, and pharmacology. Here, I would like to mention one more thing, that meta-AI did not achieve 100% accuracy in any subject, even if we combine the results of both the initial and rescored analysis, which means that even though meta AI performed impressively, it still demonstrates occasional variability and definitely a room for improvement. Lastly, in table number 1, we can see there is a significant difference between the accuracies of initial and rescored analysis. This suggests that even though AI models get better with repeated attempts, they still require a considerable amount of time in order to generate accurate and meaningful results. Moving further and discussing our findings, Meta AI showed a strong potential in delivering thorough and precise medical information, especially considering a fact that it is relatively a newer model. But still, it falls well short of being totally trustworthy. Meta AI performed better with the clinical-based questions as compared to the fact-based questions. However, this comparison did not reach any statistical significance. Compared with the initial accuracy of 77.9%, the net mean accuracy improved to 82.9%. This is a better improvement in terms of a relatively newer model, and this might suggest impact of repeated user feedbacks and reinforcement learning mechanisms that are involved in these AI model updates. Lastly, additional meaningful comparisons were not possible with the previously published literature because there is little to no research data available on Meta AI. Also, there are differences in the study design and assessment methods in the previously published articles. Our study offers a preliminary evidence that AI-based systems may be able to respond to multiple choice questions with factual and scenario-based solutions both, and certainly with additional validations, Meta AI could be an invaluable tool for the quick retrieval of the medical information in our fast-paced clinical life. We had a few limitations. First of all, we included only a small set of questions with only 30 questions from each subject. Secondly, due to resource constraints, clinical sciences subjects were not used. Only the study was only limited to the basic sciences subjects. Then the selection bias could have influenced the results, as there was no blinded or automated question picking system involved, and the questions were randomly chosen manually. And lastly, of course, additional meaningful comparisons were not done with the literature, as there was no relatable literature found at that moment. For future recommendations, we would like to recommend that the future researchers confirm the accuracy of this model using a relatively larger set of data that correctly represent the whole medical curriculum. And of course, these type of researches must be done in collaboration with medical institutes to make sure that these systems are being updated in line with the latest medical knowledge and guidelines. To conclude, Meta AI has shown strong potential in transforming the way we assess and learn medical information. However, the current version still requires cautious use. The healthcare workers must be trained to understand both the benefits and the limitations of these AI tools, and they must make sure that these systems support rather than replace the informed human decision making. These are the references, and thank you everyone for listening. I'm happy to take your questions now.
Thank you so much for that excellent presentation, Ms. Khan. We'll now open the floor for questions for our judges.
Hi, I have a few questions. So did you compare the accuracy of Meta, this language model, with other large language models?
We wanted to do so, but the problem that arose at that moment was the fact that
I think you're muted.
made it really difficult to compare this particular study with the results of those.
Okay. And the other issue is the 22.6%.
Can you hear me?
Yeah, I can hear you now. The other question is that you had 22.6%
Yes,
reproducibility later. What do you think is the reason for that?
Yes. So basically, the AI models or the large language models, they are designed to get better with the repeated user feedback and the reinforcement learning mechanisms. So this is the main principle that might have acted to improve the feedback, the response of the Meta AI, this AI tool. Secondly, the updates that are being done in these AI models or large language models, they might also be responsible for the updated medical information and the fact that AI produced better result after reevaluation.
Okay, and was there any model variability in that 14-day period, or was there any change in the prompt format?
No. We made sure that there is consistency maintained in the prompt format, as well as we also made sure that the same author enters the data in the reevaluation as well as that who has done it in the initial analysis, so that there is no differences from the side of the author or entering the questions.
Okay, thank you so much.
Thank you so much.
Hi, Ariba. Thank you very much for the presentation. Very interesting. I think this is a hot, sexy, cool topic everybody is facing around the world. Everybody wants to know about it and tell me about it. When we think about the application, and certainly one of the challenges when we think about large language models and all the various applications out there, Meta and ChatGPT, others. Certainly, I think your study highlights what other studies have highlighted, that there's relatively high initial accuracy, but then poor reproducibility, right? And so we think about, and I want you to kind of think about you thinking a forward-looking statement. When you think about this research and what you found, and I realize you're still a medical student, what do you think this actually means from a practical reliability of using Meta or any other large language model in real-time clinical decisions?
That's a very good question. And what I think medical learning, basically these models, they can never replace the informed human decision making, but they can support the decision making, because if these models are trained with the real life scenarios or real life clinical scenarios, to be very specific, they can generate the exact medical information that can be generated by a human mind after thorough or precise textbook overview. They can actually help in reinforcing the clinical judgment if they are accurate enough, if we make sure that they are accurate enough in producing the medical information. Definitely they cannot replace the informed human decision making, but they can support it.
Yeah, excellent.
Additionally,
Yeah,
I am not currently very sure about the real practical implication. What I have done from my part is that
yeah, excellent. Thank you very much.
Thank you very much.
Thank you, Ms. Khan, and thank you, judges, for your questions. Feel free to take this transition time to submit your judging response form. We will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Now we will move on to our next presenter, Dr. Shiraz Qasim from Pakistan, presenting their original research entitled Emotional and Psychological Dependence of Medical Students on Artificial Intelligence Chatbots, a Cross-Sectional Study.
Yes. Ever wondered if a chatbot can become more than just a study tool, like a friend you depend upon? My name is Qasim. I'm a second year medical student in Amiruddin Medical College, Lahore, and I'm honored to present our research on emotional and psychological dependence of medical students on artificial intelligence chatbots, a cross-sectional study. So, medical students are a population that deal with high stress situations. Observational evidence suggests that their mental health is suboptimal as compared to general population. The reasons being academic overload, social and competitive pressures, time pressure and burnout, and emotional and psychological factors like imposter syndrome, social isolation, and exposure to suffering. So, in the midst of all this, going through a roller coaster of emotions, they must find ways to process their emotions and make sense of their feelings so they don't get dragged along. But there are limited avenues for emotional support due to time constraints, peer pressure, social isolation, and fear of judgment. And here comes the role of artificial intelligence chatbots, offering parasocial interaction as confidant, as counselors, but there is a catch here. These chatbots do help, but dependence on them affects emotionally vulnerable individuals. OpenAI chatbots developer estimated that 0.07% users in a given week out of 800 million users show possible signs of mental health emergencies like psychosis and mania. So it's important to understand how medical students interact with these chatbots for their emotional and psychological regulation, navigating through a highly stressful environment. The objectives of our study are to assess emotional and psychological dependence of medical students on these chatbots and to identify the predictors like satisfaction, emotional expression, regional stratification, academic standing, and gender that influence this interaction and to assess how satisfaction mediates dependence pathway. It was a national cross-sectional survey conducted in July-August 2025 among medical students across Pakistan. An online questionnaire was separated using WhatsApp, LinkedIn, and other social media platforms, and anonymity was assured. We recruited data collectors from different provinces to ensure broad geographic representation to increase the generalizability of our findings. Ethical Committee of Amiruddin Medical College, Lahore approved this study and informed consent was obtained from each participant prior to their enrollment. Our study complied with the STROBE guidelines. So the domains in our questionnaire were demographics, chatbot usage pattern, emotional expression, psychological help, and emotional and psychological dependence. It was assessed via large language model D12 scale and satisfaction. We classified dependence using the bell curve approach and a robust analysis was performed. This slide shows our detailed analysis plan as the data was prepared, cleaned, and descriptive statistics, inferential statistics, predictive modeling, and subgroup analysis were performed along with advanced models of mediation and moderation. We performed a reliability analysis on our questionnaire and the Cronbach's alpha values range from 0.78 to 0.9, in which ensures the integrity of our questionnaire. We collected 1,063 responses, out of which 1,045 responses were considered valid, and 986, which is 94% respondents reported chatbot usage, with more than 50% using these bots daily and 85% using them at least once a week. The table highlights that male and female responses were almost equal and 75% responses were from public institutions. We found out that 68% students demonstrated moderate overall dependence and 18.36% demonstrated high relationship style dependency. We found no statistically significant difference between dependence scores of male and female students, which implies that both genders are interacting with these chatbots equally for their emotional and psychological regulation. So the post hoc analysis, this signifies the emotional dependence and academic performance association. As you can see, the students with excellent academic performance demonstrated lower emotional dependence scores as compared to the students with good academic performance. We performed a focused analysis on participants from Punjab. It revealed that students from private institutions showed higher emotional dependence as compared to students from public institutes. This heat map is the correlation matrix that shows that all psychological scales used were strongly and positively intercorrelated. This slide confirms that these psychological traits and behaviors move together in our participants. Notably, emotional expression and seeking psychological help were very strongly related. So was relationship style dependency and using chatbots for psychological help. So, what predicts emotional dependence? And that is one of the main questions. And multiple regression identified satisfaction as the strongest predictor for emotional and relationship style dependency. As you can see, as the satisfaction score increases, emotional dependence score also increases, and relationship style dependency score also increases, followed by psychological help seeking and emotional expression. So, this is our core finding, I think, what makes our research an important addition to the literature in this domain. The mediation role of satisfaction in driving this pattern between emotional expression and emotional dependence. As we talked earlier, observational evidence reports that these chatbots help mitigate loneliness, but over-reliance risks dependence, which leads to dangerous circumstances. Our study has certain limitations due to its cross-sectional design. We cannot infer a direct cause and effect relationship. Risk of selection bias also persists. We used bell curve approach, which lacks psychometric validation, self-reported data, confounding residual effects from unmeasured factors like coping styles. Regional analysis could not be performed. We could not establish provincial trends due to recent flood situations that limited data collection across provinces, and their temporal limitations and statistical issues. To conclude, medical students show moderate dependence on AI chatbots driven by satisfaction. The mental well being of medical students is closely related to both their academic performance and future clinical practice, underscoring the importance of understanding these dynamics. Guidelines implementation are to develop and enforce policies for responsible AI integration in medical education and longitudinal monitoring. Future research should explore the long-term impact of chatbot dependence on students' learning, professional development, and psychological well-being. Thanks for your time.
Thank you for that excellent presentation, Dr. Qasim. We will now open the floor for questions from our judges.
Dr. Dali, you want to go first or you want me to? I don't know who's going first. I never know the rotation.
Yeah, I can go first.
Okay.
So Shiraz, it's a really nice presentation. You define that, so in your study, how did you define the dependence operationally for AI? I mean, what I mean is, how do you know that the dependence was for AI and not for just tech dependence?
We used large language model D12 scale, which is specifically for artificial intelligence models.
Okay. And the other thing I was thinking of is, because you have looked at dependence, did you adjust for pre-existing any mental health concerns in your participants?
Yes, our questionnaire had a question, and 22% students, they reported mental health condition, and they were excluded from this study.
Okay. When you say that they reported mental health condition, do you mean it was a self-reported?
Self-reported, yes.
Okay.
Self-reported.
Okay. And how did you define the thresholds, like the low, moderate, and high dependence?
That was a bell curve approach, meaning mean plus standard deviation method. So that if the score fell below mean minus standard deviation, that we categorized as low dependence. Mean minus standard deviation to mean plus 1 standard deviation, we categorized it as moderate dependence, and mean plus 1 standard deviation, we categorized it to high dependence.
Do you think that in this, for your study, the clinical cutoffs might differ from your statistical cutoffs for categorizing low, moderate, and high dependence?
Yes, that's a possibility. Of course, that's a possibility. And we are trying to explore factor analysis to establish proper facts.
Okay.
That's our future approach.
Okay. Thank you
Thank
so much.
you. Thanks. I appreciate your question.
Hi, Shiraj. Thank you very much for presentation. Interesting topic. Again, I think this is one of those that everybody is trying to wrap their head around with the use of AI, and it's prolific. I think it's interesting what is happening, and I don't know how it is in Pakistan, but you did your whole study around the emotional and psychological toll of medical school there. I don't know how it is there, but in America, there is no psychological toll. I'm just kidding, just kidding. In seriousness, we think about what you were talking about with this whole dependence on chatbots. And I get it, and this is a concern, but how is this different or maybe even more concerning than when you compare it to other traditional forms of emotional coping like social media? How is this different?
So I can only give a personal opinion, I think, on this question. But there is a recent BMJ report published, I think yesterday or one day before, that reported that I stated that too. 0.07% users out of 800 million weekly users reported mental health emergencies like psychosis and mania. So that's adverse effect of this. I think that.
And this is more concerning with chatbots than you think with social media.
I think as we move forward and more we get more and more data about this, then we will be able to state that as a fact. It's just an opinion. It can be just an opinion for now, I guess.
Yeah, sure. One final thought here. Dr. Dolly had asked you about thresholds. I want to take that one step further. Did you identify any threshold at which dependence on these chatbots begun to have some sort of, I don't know, negative impact on, academic performance or mental health outcomes? Was that part of this? Did you guys look at that?
No, that was not part of that. We just assessed emotional and psychological dependence because in Pakistan, actually, it's a mental toll. Medical college, it's a mental toll. But how do you process your emotions then? You use chatbots. I think when I started research, I got this example a lot. I got rejected many a times. Then I needed to turn to these bots to keep me going, to kind of motivate me. But I cannot say that I didn't move forward according to your insight, because I did not know how many medical students are actually using these bots for their emotional and psychological regulation. And it's a lot. 68% demonstrated moderate overall dependence. Then it's a lot.
Yeah. Excellent. Yeah. And I just want to reassure you, there's nothing unique about medical school in Pakistan. It's a mental toll for everybody everywhere around the world. So there you go. Thank you very much.
Yeah, we enjoy this mental toll. We choose it ourselves, actually. Medicine, I think if you fall in love with medicine, you're going to do great.
There you go.
It's a mental toll. We can bear it.
Great attitude. Thank you.
Thank you. I really appreciate the opportunity. Thanks.
Thank you so much, Dr. Qasim, and our judges for the excellent question. And as a medical student in the United States, I agree that the mental toll is everywhere. Okay, so now we will be displaying a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Remember, your votes will help determine the awards we will announce during tomorrow's award ceremony, so please don't forget to participate. And judges, please take this transition time to submit your judging response form. Thank you. And now we will be moving on to our next presenter, Dr. Levent Özdemir from Turkey, who will be presenting their original research on occupational exposure to blood and body fluids and anxiety among final year medical students, the results of the curricular gaps in medical education. Welcome, Dr. Özdemir, and please go ahead and proceed whenever you are ready.
Hi everyone, my name is Levent Özdemir. I'm a professor at Bursa Uludağ University, Faculty of Medicine, Department of Public Health. It's a great honor to present our study titled Occupational Exposure to Blood and Body Fluids and Anxiety Among Final Year Medical Students. This research was carried out together with my students. They were seniors at the time of the study. They graduated last June. They informed me that they were unavailable on the Congress dates. Therefore, I will make the presentation. Their names are as follows. Tena Sude Özyar, Sabrina İsrafilzade, Behrok Horosani. Occupational exposure to blood and body fluids is one of the most common hazards for healthcare professionals. Medical students are particularly vulnerable during their first clinical rotations. These exposures can cause not only biological risk, but also psychological distress, including anxiety and fear of infection. Our study aimed to determine how frequently final year medical students are exposed to blood and body fluids, to examine whether these exposures increase anxiety levels, and to identify possible weaknesses in current safety training. We conducted a cross-sectional study in early 2025 with 203 final year medical students. Data were collected through an online questionnaire that included demographic information, exposure history, and the Generalized Anxiety Disorder 7 scale. We used negative binomial regression to identify predictors of anxiety severity. Our study included 203 students, 59% were female and 41% were male. Over half of them reported at least one exposure to blood or body fluids, and 2/3 experienced multiple exposures. The most common causes were venipuncture and arterial puncture. Emergency departments posed the highest risk. Although most students reported using personal protective equipment, full protection was rare. Everyone used gloves, but only 59% wore masks, and just 70% used gowns. The main contributing factors were long working hours, pressure from assistants, and lack of experience. Half of the students screened positive for anxiety symptoms, and nearly 8% had severe anxiety. The mean generalized anxiety disorder 7 score was significantly higher among those who were exposed, 7.2 compared to 5.4 among unexposed students. The difference was statistically significant. Our regression model showed that exposure increased anxiety by 34%. Working in high-risk departments such as emergency or surgery raised anxiety by over 50%. Psychological factors like performance anxiety had even stronger effects than exposure itself. These results highlight that safety training alone is not enough. Students need hands-on experience and emotional preparedness. Practical simulations and mentoring are key to reducing both physical risk and anxiety. Improving the learning environment can prevent repeated exposures. In conclusion, occupational exposures among medical students are frequent and strongly linked to anxiety. Despite formal instruction and access to simulation lab at Bursa Medical School, students still struggle with stress, procedural errors, and low personal protective equipment compliance. Our recommendations as follows. Simulation-based a clear gap between theoretical training and real clinical performance. High-fidelity simulations help students practice under realistic pressure, improve mastery of basic procedures like venipuncture, and reinforce consistent personal protective use. Integrating stress management techniques such as cognitive behavioral training, promoting a culture of safety where students feel supported to report incidents without fear, and monitoring personal protective equipment use. Thank you very much for your attention.
All right. So we'll now display a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation coming up. And judges, please go ahead and take this transition time to submit your judging response form. Thank you. All right, let's move on to the next presenter. Miss Julia Jaromirska from Poland, who will be presenting their original research entitled Evaluation of HMBG1 serum levels and its involvement in depressive symptoms in obstructive sleep apnea patients.
Good morning, everybody. My name is Julia Jaromirska, and today I want to present to you my research presentation, evaluation of HMBG1 serum levels and its involvement in depressive symptoms in obstructive sleep apnea patients. But first, a couple words about myself. I'm a 6-year medical student. I'm the head of the Student Scientific Club sleep team in the Department of Sleep Medicine and Metabolic Disorders at the Medical University of Łódź in Poland. And also, I'm the project leader of 2 university grants with a funding of around 10,000 euros. My today's project concerns patients with obstructive sleep apnea. It is a disease characterized by repetitive upper airway obstruction, leading to apneas and hypopneas during sleep, as well as chronic intermittent hypoxia and further excessive daytime sleepiness. Patients with obstructive sleep apnea are at increased risk of developing depression and mood disorders. High mobility group box 1, abbreviation HMB-GB1, may be a molecular bridge between hypoxia and depression development, as its protein plays a role in neuroinflammation. That is why the relationship between chronic hypoxia, depicted by HIF-1 alpha activity, and HMDB1 levels may act as a self-perpetuating circle leading to symptom aggravation between depression and obstructive sleep apnea. And our goal was to check this hypothesis, to assess the protein concentrations in obstructive sleep apnea patients and examine their relationship with polysomnographic parameters, hypoxia-inducible factor 1 alpha, and depressive symptoms. And in our study, we included 152 participants and divided them into 4 groups depending on obstructive sleep apnea, occurrence, and depression status. Every participant underwent overnight hospitalization in our department, including physical examination, psychiatric evaluation, and we used Montgomery-Åsberg Depression Rating Scale and Insomnia Severity Index. Also, there was an evening blood collection, overnight polysomnography, and morning blood collection. We examined HMGB1 and HIF1 alpha levels using ELISAs. And also, we performed statistical analysis. Turned out that statistically significant was that the protein levels differed between groups. Controls had lower concentrations compared to depression and ASA plus depression. In addition, across all participants, HMGB1 correlated with Montgomery-Åsberg Depression Rating Scale scores, but not within the subgroups. What is interesting for us is that the protein and HIF1 alpha were correlated in the whole sample, and particularly in depression and obstructive sleep apnea subgroups. But no association was observed between OSA severity and HMGB1 levels. And as Rolling Stones once said, you can't always get what you want. And it may be the conclusion of our study because elevated HMGB1 is linked to depression and relates to depressive symptom severity independent of OSA presence. However, it may be connected with HIF1 alpha activity connected to chronic intermittent hypoxia, and the dysregulation of depression protein can contribute to depression development, warranting future investigation in the term of our disease. But our future questions are, how does it work? Can it be a future biomarker of exacerbated risk of developing depression in the course of chronic hypoxia, not only in obstructive sleep apnea, but in other diseases? Yes, that's our future questions. Thank you for your attention. And if you have any other questions or you want to know more about the area of research that we do in Poland, feel free to scan QR code. Thank you for your attention once again.
Okay. All right. As this video just ended, we're going to have to skip the Q&A session because she is not present with us today, and we're going to move on to our next presenter, but I'm going to put the QR code up for everyone to vote.
Sounds good. We are sad to have missed Miss Yulia, but thank you so much for her excellent virtual presentation. So now we'll be moving on to our next presenter, Miss Anastasia Kolesnykova. I'm so sorry if I did not pronounce that correctly, from Ukraine, who will be presenting her original research entitled Hand Grip Strength Asymmetry in Middle-Aged and Older Adults Clinical Aspects.
Everyone, my name is Anastasia Kolesnykova. I'm a 6th-year medical student at Ivan Horbaczewski Ternopil National Medical University from Ternopil, Ukraine. It is an honor to me to present to you my research study on hand grip strength asymmetry in middle-aged and older adults clinical aspects. Background. The search for early predictors of neurodegeneration remains an important challenge. Several studies have demonstrated a link between hand grip strength asymmetry and accelerated cognitive decline in middle-aged and older individuals. Aim. This study aims to determine the clinical aspects of hand grip strength asymmetry in middle-aged and elderly patients. Methods. A total of 90 of middle-aged patients, mean age 63.71, were examined. Gender distribution. Men 58.9%, women 41.1%. Inclusion criteria. Ages over 45 years, preserved hand functions, absence of paresis, joint pathology, or pain syndrome. Hand grip strength was assessed using an electronic hand dynamometer. An asymmetry coefficient, the ratio of maximal hand grip strength of the non-dominant hand to the dominant hand, was calculated. A value less than 0.9 or greater than 1.1 was considered indicative of asymmetry. A statistical analysis was performed using Statistica 11. On the slide, you can see an electronic hand dynamometer, CarenMap 130K1, and the table with the results of its measurements. Cognitive function was assessed using the MoCA test. Anxiety and depression levels were evaluated the hospital anxiety and depression scale. On the slide, you can see them. Some of the results: mean hand grip strength value were 28.54 kilograms for the dominant hand and 25.89 kilograms for the non-dominant hand. Maximum recorded hand grip strength values were 28.82 kilograms for the non-dominant hand and 30.74 kilograms for the dominant hand. Cognitive function in the overall sample MoCA test was 23.68 points. The hospital anxiety and depression scales showed depression 5.81 points and anxiety 7.39 points. The correlation between MoCA test and age was equal to minus 0.39, and the correlations between MoCA and anxiety was equal to minus 0.32. Hand grip strength asymmetry was diagnosed in 49 patients, 54.4%. Asymmetry in the dominant hand was present in 38 patients and in the non-dominant hand in 11, 12.5%. The mean age in the asymmetry group was 62.21 years and 61.97 years in the non-asymmetry group. Patients with asymmetry had significantly lower MoCA scores, 22.76 compared with those without asymmetry, 24.77 points. Significant declines were observed in the domains of visual constructive skills, 1.67 points with hand grip strength asymmetry versus 2.58 points without asymmetry, and memory 1.61 versus 2.11 points respectively. In the asymmetry group, correlation were found between gender and muscle strength was equal to minus 0.7, and muscle strength and MoCA was equal to 0.34. Our conclusion: hand grip strength asymmetry was diagnosed in 54.4% of middle-aged and elderly patients. An inverse correlation between an asymmetry coefficient and MoCA scores was established. Thank you for your attention.
Thank you for the virtual presentation. We are sorry to have missed you, but we will now be transitioning to our next presentation. But before we do that, we're going to display a QR code for audience voting. And judges, please take this transition time to submit your judging response form. Thank you. Now we will be moving on to our next presenter, Dr. Bashir Babaa from Palestine, who will be presenting a case report entitled Aggressive Gallbladder carcinoma in Down syndrome patient, a rare presentation.
My name is Bashir Babaa, a PGY1 radiology resident at An-Najah National University, Nablus, Palestine. I am pleasured to present our case titled Aggressive Gallbladder Carcinoma in Down Syndrome Patient, a Rare Representation. This work was done in the collaboration with colleagues from Al-Quds University. Next, please. All right, as we know, individuals with Down syndrome have a higher risk of developing hematologic malignancies, but not solid malignancies. Among solid malignancies, we'd like to present gallbladder carcinoma, which is a rare representation. Multiple proposed risk factors in such a cohort, including increase the propensity of cholelithiasis in patients with Down syndrome, and cholelithiasis is one among the strongest risk factor for developing gallbladder cancer in general. Chronic inflammation, H. pylori, colonization, chromosomal instability, and cytogenetic abnormality of chromosome 21. Next, please. Our patient is a 45-year-old male with Down syndrome, presented with a chief complaint of epigastric pain for 3 days, jaundice for 5 days, associated with postprandial nausea and vomiting, but the patient denied any history of dysphagia, anorexia, bowel habit changes, or GI bleeding. Next, please. On clinical examination, there were distended abdomen, yellowish discoloration of skin and mucous membrane, mild epigastric tenderness, and palpable bulge in the right upper quadrant. These constellation of features raised the suspicion of hepatobiliary disease or gastrointestinal disease. Next. Going for labs turned back positive for elevated inflammatory markers such as CRP, elevated white blood cell count, direct hyperbilirubinemia, hypocalcemia, mild anemia, and hypoalbuminemia. Surprisingly, liver and pancreatic enzymes were unremarkable. So this suggests that a simple gallstone-related disease is unlikely. Next, please. Going for radiologic imaging, ultrasound revealed moderate to severe ascites in addition to multiple focal hepatic lesions, which warranted escalating the level of radiologic imaging. MRI of the abdomen was done, showing a large exophytic hepatic mass encasing and compressing the gallbladder and multiple other focal hepatic lesions. There was also a right-sided adrenal mass and speculated periportal mesenteric lymph nodes, in addition to thickening of the ascending colon. These findings were suspicious for metastatic malignancy with gallbladder involvement, so a triphasic CT was also performed and confirming the same results. Next, please. Here are multiple slices of MRI and CT scan imaging showing a large exophytic mass, especially in the T-weighted MRI, T-weighted image in image B. The white circle shows the exophytic mass, which compresses and engulfs the hyperintense gallbladder. Next, please. So where we are in our case, there is a suspicion of a metastatic disease with hepatobiliary involvement. So where is the primary disease? As we said previously, that there was a thickening of the ascending colon. So a colonoscopy was performed to rule out colon cancer, but it showed normal mucosa and histopathology was unremarkable. Next. what revealed the primary cancer and confirmed the diagnosis is a core biopsy of the liver, which showed moderately differentiated adenocarcinoma consistent with gallbladder carcinoma with hepatic metastasis. Next. The TNM stage was consistent with stage 4. Unfortunately, the management plan was focused on symptomatic and palliative management instead, or rather, of aggressive measures. The patient was admitted given IV fluids, proton pump inhibitors, antibiotics, analgesics, kept NPO, and diuretics. Later on, ursodeoxycholic acid and hydrocortisone were added to the regimen, and ICU management included gastric protective measures, electrolyte repletion, and unfortunately, despite escalation in management, the patient clinical status progressively deteriorated, and finally, the patient deceased. Next. Key insights regarding our case. Our case adds to the SCAR evidence that gallbladder cancer is a cancer with a dismal prognosis, which carries an extensive systematic spread at diagnosis, highlights aggressive course and later presentation of gallbladder carcinoma in patients with Down syndrome, and that it requires histopathologic confirmation. Next, please. Broadly, our study stresses the importance of high index of suspicion of hepatobiliary cancer or of gallbladder cancer in patients with Down syndrome. So we should consider early imaging or screening in such individuals. And the scarcity of reported cases may reflect underdiagnosis or early mortality from other comorbidities. So making large studies is essential to define true incidence and guide better care, hopefully. Next, please. Thank you for your attention.
Thank you so much, Dr. Babaa, for the excellent presentation. We will now be moving on to questions from our judges.
You are welcome.
Okay, I can go first, if that's all right. It's a nice presentation, Dr. Babaa. I have a few areas you can comment on. You told that this patient already presented with a stage 4 disease.
Yes.
Was there any consideration of any disease modifying, any palliative chemotherapy at that point?
It is the clinical status of the patient plus the stage he presented with showed that he is not a good fit for chemotherapy such as cisplatin or whatever, unfortunately.
And you also mentioned that in a patient with Down syndrome, one has to keep high suspicion of hepatobiliary malignancy. However, I do wonder, because this is a usual presentation of gallbladder carcinoma in a usual population who doesn't have Down syndrome. So do you think it was just a coexistence of Down syndrome and gallbladder rather than a correlation?
Thank you for asking this question. Patients with Down syndrome have an increased propensity of cholelithiasis and cytogenetic abnormalities. So this may be not a true coincidence. There should be a link between this. So larger studies are recommended to link this area of dilemma, let's say.
Okay. And you also mentioned that there was direct hyperbilirubinemia. However, LFT was normal. And how do you think that is physiologically possible?
All right. This question is great because we do expect that in a patient with direct hyperbilirubinemia, alkaline phosphatase would be normal. It may be due to the shrinkage of the hepatobiliary system from the invading tumor, I guess.
Okay, but there was extensive metastasis, wasn't it, in the liver?
Yes, yes.
Okay, okay,
Maybe the cancer replaced the normal tissue.
okay. Thank you so much.
You are welcome.
Thanks, Dr. Babaa, for a great presentation, interesting case. I guess my question is thinking about this in the context of, as you, it was in the title, and as you talked about, rightfully so, that this is a rare presentation. And so thinking in that context, and given the patient's advanced presentation, do you think as a result of seeing this case, do you believe earlier imaging for hepatobiliary complaints in I guess mostly in Down syndrome, should that be part of some sort of screening guidelines or treatment approach?
Thank you for asking this question. It is truly difficult to tell that this is true from such a case report. So that's why we said in the conclusion that we require larger studies, maybe systematic reviews, to make a strong relationship to declare such a screening protocol.
Yeah. And I think that's, my next question. Elaine, do we have time for one more question?
Yeah, go ahead.
Yeah. Okay. My final question in thinking about this is, given that gallbladder disease and gallbladder carcinoma is rare in Down syndrome, and you think about, again, this case, I'm just curious, why'd you even do this? What was significant about this, and how does this case contribute, something meaningful or unique to the literature that goes beyond just kind of pointing out something rare?
Thank you. Maybe that patients with Down syndrome are usually not able to express their concerns or their symptoms. So we have to intervene here to make them safe, to make a screening protocol that detects things earlier.
Yeah. So you're speaking on behalf of the patient. Yeah. Good. Yeah. Thank you for that. Thank you.
You are welcome.
Great presentation. Thank you.
Thank you so much, Dr. Babaa. So now we'll be moving on to the QR code for audience voting. And thank you, judges, for your questions. Please feel free to take this transition time to submit your judging response form. And if we can put up the QR code for audience voting, please go ahead and scan the QR code to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's award ceremony. So please don't forget to participate. Thank you. Next, we will be moving on to our presentation by Dr. Yogeshwaran Mohan from India, who will be presenting a case report entitled Silent Splenic Crisis in an Immunocompetent Adolescent, a case report of multifocal splenic abscess with subcapsular extension and paradoxical leukopenia managed conservatively.
My topic for today is silent splenic crisis in an immunocompetent adolescent. A case report of multifocal splenic abscess with subcapsular extension and paradoxical leukopenia that's managed conservatively. So the authors are my guide, Dr. Amit Kumar, Doctor of Medicine, Associate Professor, Internal Medicine, ESIC Postgraduate Institute of Medical Science and Research, New Delhi. Dr. Shweta Tanwar, MPH Scientist, Indian Council of Medical Research, New Delhi. Dr. Yogeshwaran Mohan, MBBS, Final Year Resident, Internal Medicine, ESI Postgraduate Institute of Medical Science and Research, New Delhi. Dr. Aman Dubey, MBBS, Second Year Resident, Internal Medicine, ESI Postgraduate Institute of Medical Science and Research, New Delhi. So I am the presenter. About me, I'm currently final year resident in the Department of Internal Medicine in ESI Postgraduate Institute of Medical Science and Research, New Delhi, India. And I'm passionate about medical gastroenterology and would like to pursue clinical research and would want to contribute really high to quality patient care. About the background of my case. Primary splenic abscess is a rare clinical entity with a reported incidence ranging from 0.05 to 0.7%, and is especially uncommon in immunocompetent individuals because spleen's robust phagocytic and immunological functions generally confer protection against microbial invasions. Most splenic abscesses are secondary to hematogenous seedings, frequently in the setting of infective endocarditis, immunosuppression, diabetes, trauma, or intravenous drug use. The clinical presentation is also vague, with a classical triad of fever, left upper quadrant pain, and leukocytosis. It's usually present. That also usually is present in minority of the cases. And the diagnostic challenge is compounded by non-specific symptoms, frequently with sterile blood cultures. Imaging modalities, particularly computer tomography, they play a central role in diagnosis. And surgery has long been the main treatment for splenic abscess, but there's now a growing preference for less invasive options like targeted antibiotics and image-guided percutaneous drainage. However, the optimal treatment approach remains uncertain. Percutaneous drainage can be a useful option in selected cases, but studies have reported high failure rates ranging from 14.3% to 75%. That's quite seriously a high number of failure rate. Moreover, even with advances in imaging and treatment, delayed diagnosis or inadequate treatment carries a high mortality risk. So I would like to report a case of a 15-year-old immunocompetent patient. And my aim is to highlight the importance of early diagnosis and successful conservative management. So my case here is a previously healthy 15-year-old female who presented with a 10-day history of high-grade fever, abdominal pain, which localized to left upper quadrant and became sharp and positional in nature. She had no history of recent infection or immunosuppression or trauma or chronic illness. And she experienced transient arthralgias but displayed no gastrointestinal or respiratory symptoms. Clinical examinations revealed left upper quadrant tenderness, splenomegaly. And lab investigations showed profound leukopenia, WBC count of 2100, and with neutropenia of absolute neutrophil count of 800. And she had normocytic anemia of hemoglobin about 9.2. She also had high procalcitonin, which was elevated to 8.2 nanogram per milliliter, while the blood culture still remained sterile. Imaging findings. Ultrasound and computer tomography revealed an enlarged spleen with multiple hypodense peripherally enhancing lesions, the largest measuring 53 into 39 into 58 millimeter, with subcapsular extension and perisplenic fat stranding. So here is an image showing multiple hypodense lesions. So coming to the diagnosis and the treatment part. Initial empirical therapy with ceftriaxone and metronidazole was ineffective. Ultrasound, so we did an ultrasound guided aspiration which yielded about 50 ml of pus, and we sent it for culture. Culture aspirate grew Klebsiella pneumonia, and we promptly escalated the antimicrobial therapy to intravenous meropenem and teicoplanin. So over the next 2 weeks, the patient showed complete resolution of fever and significant symptomatic relief. So the outcome was complete symptomatic recovery. The patient was discharged stable with no complication, and follow-up ultrasound at 1 month showed normal splenic architecture and then complete resolution of abscess. As we can see in the follow-up ultrasound, there is complete resolution of the abscess and then splenic architecture has been regained. So what is the clinical significance? Early imaging here is in key febrile patient, especially with abdominal pain, is the key to early recovery here. Conservative approach with image-guided aspiration and targeted antibiotics are effective alternative over surgery. As we have seen previously, surgery holds a high mortality rate, even up to 75%. So this entire process at last preserves the splenic function and minimizes complications such as going for a splenectomy. So conclusion. I would like to conclude that this case emphasizes the importance of maintaining clinical vigilance, early imaging in febrile patients, even in absence of typical risk factors for deep-seated infections. It demonstrates that conservative management, including image-guided aspiration and targeted antibiotic therapy can be a safe and effective alternative to surgery in selected cases. With timely diagnosis and an individualized treatment approach, it is possible to achieve complete resolution while preserving the splenic function and minimizing procedural risk. This case supports the evolving paradigm towards less invasive strategies in managing splenic abscess, particularly in stable and immunocompetent patients. Yeah, thank you.
Thank you for that excellent presentation, Dr. Mohan. We will now open the floor for questions from our judges.
I can go, okay. Thank you, Dr. Mohan, for presenting this nice case. I have a question regarding the clinical reasoning and the clinical decision-making in this case. You have mentioned that this was a multifocal splenic abscess, yet you chose intervention, you mean aspiration and antibiotics, and not going for surgery. And I'm also a little concerned because there was subcapsular extension. So weren't you concerned that this patient can go into a splenic rupture leading to intra-abdominal spillage of the pus? So what was the rationale behind going for a conservative management?
Yeah. To begin with, the early imaging, the entire case speaks about early imaging. So as soon as we had abdominal pain with fever for a long time, we did an early imaging. We had high index of suspicion. So early imaging, even though there was subcapsular extension, it was not big enough to cause a rupture. And previous studies from what we have seen causes high mortality while we do a surgery. The patient was still within this window where we could go with the culture, and then we started the antibiotics. As soon as there was a recovery, we put the patient on standby as well. I have to be honest, in case those don't work. But miraculously, the antibiotic did work, and the patient had a complete recovery. So we opted out of surgery. That's the entire point of presenting this case, where I could go with antibiotics and conservatively manage and avoid the surgery.
Yeah, and one of the clinical features was leukopenia and neutropenia, isn't it? How do you think? What do you think was the pathophysiology behind that in a splenic abscess patient? Don't you think that there will be increased neutrophil count when you have such bacterial infection, especially gram-negative bacterial sepsis?
Yeah. So as we would have seen, that's a paradoxical leukopenia. Usually, in case we have any infective foci in our body, we usually see leukocytosis or neutrophils, a lot of neutrophils. But in this case, since their spleen was involved and then there was a splenomegaly also, so a sequestration was involved. There is splenic sequestration of all the cells. If you would have also seen, there was anemia 9.2, and since spleen eats up all our cells, so there was apnea.
Thank you so much
Thank you so much, Dr. Dali.
Thanks, Dr. Mohan. Great presentation, very interesting. I think as a follow-up, and Dr. Dali had mentioned surgical intervention, so I just want to explore that just a little further. And thinking about, typically surgical intervention is considered first line for splenic abscesses. And I guess I'm wondering, for your perspective, how, if in any way, does this challenge sort of that very conservative management approach?
Excuse me, doctor. I have a issue listening to your audio. I'll switch the device. Can you just repeat it once more?
Yeah, absolutely. No problem. Can you hear me okay now? I heard a little bit of scratchiness. Can you hear me okay? Dr. Mohan? Okay, all right, I'll repeat. So I was just, again, asking about, was mentioned earlier, Dr. Dali had mentioned surgical intervention. So as you probably are well aware, surgical intervention is often considered first-line treatment for splenic abscesses. And I guess my question is, how does this case, if at all, challenge or maybe even support, I don't know, depending on your perspective, a more conservative management approach?
Dr. Mohan, were you able to hear us? Okay, go ahead. Yeah.
Okay, sorry about that. Okay, as I have mentioned, we specially took this case to showcase the evolving paradigm towards conservative management. Of course, it's known everywhere that splenectomy or even splenic surgeries are the first line treatment, have been first line treatment. But studies over the period have shown that they also, even though they are the first line treatment, they carry a high risk of complication, intraoperational bleed, operative complication, post-operative infections. And then splenectomy, post-operative splenectomy patients have to undergo pneumococcal vaccinations. They are prone for infections forward in life. So many cases of complications. So as I mentioned, we did have keep the patient standby for surgery in case things complicate. So we started off with the antibiotics and early imaging, and the patient pulled off really well. So in case anything went south, we would have opted for surgery, but this early intervention saved the patient, saved her spleen, and now she's leading a happy life. So
Nice.
I would again like to suggest the paradigm towards shifting conservative management.
Excellent. Thank you.
Thank you so much. Thank you so much for IJMS, and I would like to thank my mentor, Dr. Amit, also for giving me this opportunity. Thank you all.
Thank you, Dr. Mohan. We will now display a QR code for audience voting. And judges, please go ahead and use this transition time to submit your judging response form. Please scan the QR code on the screen to vote for your favorite presentation. Again, your votes were to help determine the awards we will announce during tomorrow's award ceremony, so please don't forget to participate. All right, now we will be moving on to our next presenter, Mr. Abdelrahman Salah from Iraq, who will be presenting an original research entitled Antimicrobial Resistance Awareness and Antibiotic Prescribing Behavior Among Healthcare Workers. Welcome.
Okay, good morning and good evening. My colleagues from around the world and esteemed judges. I am Abdelrahman Salah Yasser. I am undergraduate student from University of Baghdad, College of Medicine. Today we're sharing our research entitled Antimicrobial Resistance Awareness and Antibiotic Prescribing Behavior Among Healthcare Workers. So next slide, please. Antimicrobial resistance awareness, or AMR, is a growing global threat, especially in Iraq. Conflicts and weak health systems have increased multi-drug resistant infection. Also, the misuse and overprescription of antibiotics among pharmacists and nurses will exacerbate these problems. National antimicrobial resistance plans exist, but implementation for these plans is limited. So in the surveillance, they show a high resistance to Escherichia coli, Klebsiella pneumoniae, and Acinetobacter staphylococcus aureus. One health approach is needed to improve antibiotic use, surveillance, and regulation. Next slide, please. So the aim of this study, our current study conducted to evaluate healthcare workers, healthcare awareness and practices and institutional barriers to antimicrobial resistance control in a sample of Baghdad hospitals. Next slide. The method of this study was a cross-sectional survey from July to September 2025 was designed. About 196 healthcare workers across 5 hospitals in Baghdad city were involved to assess perception of antimicrobial resistance, infection control practices, and stewardship awareness. Next slide. Results. We are showing now the results of this study. Regarding the distribution of the responders, most responders were resident or pharmacists from Baghdad Medical City, which is the largest hospital or healthcare institution in Baghdad. About 86.2% of the participants considered antimicrobial resistance as a major problem. This indicative of the overall awareness of the healthcare workers in Iraq. Next slide, please. Regarding the organisms of great concern, actually, gram-negative and gram-positive were equally. In the gram-negative, the responders stated that Acinetobacter baumannii, Klebsiella pneumoniae, Pseudomonas aeruginosa were the organisms of the greatest concern. Regarding gram-positive, Staph aureus was the organism of greatest concern according to responders. Yet I must say that this is not microbiology supported. That means we don't take cultures and prove this according to a microbiology studies. We just depended on the responders' opinion of the organisms of the greatest concern to evaluate their awareness. Next slide, please. Regarding their source of information of this problem, most of them stated that they take the information from colleagues and senior doctors, which is a great gap. We see outside the Middle East and inside the Middle East, most of the healthcare workers take information about antimicrobial resistance from workshops and international meetings regarding this problem. Next slide, please. So regarding the infection control policies, stewardship programs, and the trainings, most of the responders, nearly two-thirds of the responders, stated that they have no training at all about the infection control policies. And regarding the stewardship policies in their hospital, over half of the responders stated that they have no stewardship policies. And the responders who state that they have stewardship policies, they don't know anything about it. Next slide. Wards with the highest multi-drug resistance bacteria infection rates. On the top, we have surgery wards, internal medicine ward, and intensive care unit with the gram-negative bacteria predominant in these wards. Next slide. So we conclude from this study, despite widespread recognition of antimicrobial resistance, Iraq hospitals face critical gaps in training, stewardship, and policy implementation. Nearly two-thirds of the healthcare workers never received infection prevention training. Pathogens such as Pseudomonas aeruginosa, Staph aureus, Acinetobacter baumannii were equally detected and were the most common. Multi-drug resistant infection were concentrated in internal medicine, surgery, and intensive care unit, with the gram-negative organism predominating. Urgent system-wide interventions are needed to strengthen infection control and curb the growing burden of multi-drug resistant bacteria. Next slide, please. Regarding this problem on the antimicrobial resistance awareness, we have some recommended some recommended points to evaluate this problem. Implement system-wide infection control policies, enhance regular training on infection prevention, and increase awareness of antimicrobial stewardship programs, and adopt one health approach across sectors, strengthen surveillance and regulatory enforcement. Next slide, please. So in the acknowledgement, we would like to express our appreciation, our gratitude, and humble thanks to the IJMS conference team for giving us the opportunity to present our research, and to our supervisor, Dr. Rent Riyab Hafid, for her support, guidance, and believing in our potential and what we're capable to do with this subject. Actually, she is a microbiologist in the University of Baghdad College of Medicine. And we extend our thanks to the healthcare workers who took the time to participate this study and filled out the questionnaire. And I'm sorry for the inconvenience and the technical issues that happened. Next slide, please. So thank you for your attention.
Thank you for that excellent presentation, Mr. Salah.
Thank you.
We will now open the floor for questions from our judges.
Excellent. Thank you very much. And I've always said the most stressful part of any presentation is getting the technology to work. So you were fine. And we got through. Yeah.
Thank you.
You know, when I think about this, it's an interesting situation. And I'd like to know from your perspective, there are a lot of AMR studies out there in the literature. So I guess I'm just wondering, from your perspective, what makes this research there in Baghdad hospitals uniquely impactful or even timely. So why should people care about this? Why is this interesting in sort of the global perspective of AMR discussions?
Okay, thank you. That was a very good question. So actually about the AMR studies in Baghdad and Iraq in general, there is no AMR studies, new AMR studies, and the studies regarding this problem is few in Iraq. Regarding the Middle East, outside the Middle East, the plans exist, but there is no application to this plans. Even the studies that done regarding this problem, there were no specific consideration from the healthcare institutions regarding in Iraq, and no application regarding this. Even the problem is become widely distributed in the hospitals, and it's grown very largely, but no one care about it regarding the healthcare institutions and Iraq and even the people in Iraq.
Excellent. Thank you.
Thank you.
Hi, Dr. Sela. It's a really wonderful presentation. You mentioned that there were 5 hospitals in Baghdad city, which was included in the study. Yes. I was just wondering, how does it represent the overall Iraqi population? I'm unaware of the health system in Iraq. So is it like all were tertiary care hospitals, or were there primary care, secondary care, and tertiary care mixed in? Because there are multiple AMR studies which have showed that the antimicrobial flora is quite different in different levels of care. So if you can just highlight that.
Thank you for this good question. Actually, we done our study on 5 hospitals. Regarding Baghdad, the largest hospital in Baghdad is Baghdad Medical City, which is include many institutions. These institutions like intensive care unit, various surgery wards. Our study also involves the centers of Baghdad hospitals, which is a Kindi hospital and the Yarmouk hospital. This is a large hospitals in Baghdad, even if it's not inflict the overall AMR awareness. We just mentioned that Baghdad it's covered because the largest hospitals in Baghdad were covered in this study. So we kind of the overall awareness of Baghdad hospitals and Baghdad plans were participated in this study.
Okay, thank you so much.
Please go ahead and scan the QR code on the screen to vote for your favorite presentation. And thank you, judges, and also Mr. Salah for the questions and the answers as well. And judges, please go ahead and take this transition time to submit your judging response form. And now we'll be moving on to the final presenter for our first session, Mr. Emmanuel Megbido from Georgia, who will be presenting an original research entitled From Observation to Participation, Gender Differences and Surgical Exposure Among Medical Students.
Hello everyone, my name is Nemeka Emmanuel Megbido. I'm a final year medical student at University of Georgia, Tbilisi. Today I'll be representing my colleagues on this presentation titled From Observation to Participation, Gender Differences and Surgical Exposure Among Medical Students. Surgical rotations are critical to the clinical education of medical students. As we all know, it's very, very important to even have a skill on how to suture before graduation as a medical student, especially when you are interested in general surgery. The aim was to assess the extent of surgical exposure among clinical medical students in Georgia, with a particular focus on gender-based differences in opportunities to participate actively during general surgery rotations. And this research was first of its kind in Georgia. We performed a cross-sectional study which involved students from various universities such as University of Georgia, Area State University, European University, Kakakos Universities, and Kakakos International University after we had our ethical approval from University of Georgia. Our data collection was between June 27th and July 18th, 2025. We performed our analysis using the t-test, and our p-value was at less than 0.05. You can see from the results, we had the demographic information which shows the gender difference from figure 1.0, the percentage of females to males involved in this study, and figure 2.0 as well shows the distribution of different universities that were involved. Like we had 36.5 from Area State University, which was the highest compared to other institutions. We also had final year students, more of final year students, which was 44.8% compared to 40-year and 50-year students, because in Georgia, mostly we start general surgery from 40-year before other rotations. You could also see for exposure, frequency, and t-test analysis, we performed the tables. These were the responses of the students, the frequency distribution, and the number of students involved in the study. And we also have from 2.0 the comparison between males and females experiences during the general surgery rotations, which you can see the distributions as well. Our key findings remain that males reported significant more opportunities compared to females, and it was also observed in similar studies that were performed before this. Also, female students rated overall learning lower experience with their supervisors, which was as well observed in other studies that were performed in 2020 and 2022. In conclusion, we could say that this study shows the presence of gender-based disparities, with male students receiving significant and more hands-on opportunities. We would suggest that there should be more of remedies in addressing these gaps, and there should be equitable training to ensure that students gain meaningful surgical experience, because this could affect their interest in the surgical specialty. We recommend further studies to this. These are the references we use in this presentation, and thank you very much.
Thank you very much, Mr. Emmanuel McBedo. We are sad to have missed you. So that concludes our first session. A sincere thank you to all of the presenters for their excellent work, and for our judges, Dr. Dolly and Dr. Dyer, for their time and thoughtful feedback. Please go ahead and fill out the QR code to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. And judges, thank you so much. Please take this transition time to submit your judging response form. Welcome back. We will now be proceeding with our second session of oral presentations for the day. We would like to welcome our second session's judges. First judge is Dr. Maxine Gossel-Williams, the Deputy Dean of the University of West Indies, Professor of Pharmacology. Our second judge is Dr. Sahid Mukida, Associate Professor of Microbiology and Infectious Disease at the Dr. D.Y. Patel Medical College, Hospital and Research Center in India. And finally, our last presenter, Dr. Warnar Kula-Surya Fernando Rashina Shananin, a medical doctor working in the transplantology department from Belarus. Thank you so much, judges, and we are honored to have you here. We will now be moving on to our first presentation from Miss Jelena Micic from Serbia, who will be presenting her original research entitled Vagus Nerve Neuropathy in SARS-CoV-2 Infection and Ultrasound Study. Hi, Ms. Micic. So whenever you're ready, please go ahead and proceed.
Hello, do you see my slides?
We currently cannot see your slides, but we can hear you.
Okay. And now?
Yes, we can see your slides. Please proceed.
Is it okay? Yes?
Yes, thank you. Go ahead.
Okay. Hello, good afternoon, everyone. My name is Jelena. I am a final year medical student from Serbia. It is a great honor to present our research entitled Vagus Nerve Neuropathy in SARS-CoV-2 Infection, an ultrasound study. First, I'd like to mention that there were no conflicts of interest and the study followed ethical standards. Now let's move on to the background. Vagus nerve is truly a fascinating structure, and I'm sure many of you already know its vital roles in the human body. Today, I'd like to shift focus to one of its less known functions, which is acting like a communication pathway between the immune system and the brain. And here's how this reflex looks like. When immune cells detect a pathogen, they release cytokines. Those cytokines send afferent nerve signals through the vagus nerve to the central autonomic network in the brainstem. From there, afferent nerve signals travel again through the vagus nerve to the celiac ganglion, where they trigger the release of acetylcholine. And then acetylcholine tells macrophages in the spleen to stop producing excessive cytokines. However, when the vagus nerve is damaged, for example, by a coronavirus, this reflex becomes disrupted and the immune system goes out of control. The result is hyperinflammation or cytokine storm we often see in COVID-19 patients. So, why did we choose to focus on COVID-19? SARS-CoV-2 doesn't just affect the lungs. It can also target the nervous system and damage the vagus nerve, both directly or indirectly. First, by infecting nerve cells or their supporting glial cells, which also express ACE2 receptors. Second, through generalized inflammation and systematic effects. And third, by infecting endothelial cells and breaching the blood-brain barrier. So, when vagus nerve is impaired in either of those ways, the reflex we just talked about becomes disrupted and the immune system stops working. And this might actually be the missing link that could explain why some patients develop severe complications, from pneumonia and arrhythmias to the septic shock and multi-organ failure. The aim of our study was to determine the presence of vagus nerve neuropathy in SARS-CoV-2 patients using ultrasound. This was a prospective study conducted from October to April 2022 at the Military Medical Academy in Belgrade. Our study group consisted of 68 SARS-CoV-2 positive patients, average age 53 years, and 50 healthy controls, average age 22 years. And as you can notice, our patients were older compared to the controls in this study. And this will be important when interpreting the results, so please keep that in mind. And now for the imaging, personally my favorite part of this research. We used an ultrasound, a non-invasive, bedside, and student-friendly technique to visualize cranial nerves in real time. The patients were laying in a supine position, and we placed the probe at the midline of the anterior neck. We then moved it laterally until common carotid artery and internal jugular vein could be seen. And there it was, the vagus nerve, appearing as a small, round, honeycomb-like structure. We measured its cross-sectional area, or CSA, by tracing just outside the hyperechoic rim, bilaterally, at two spots. X1 marked the carotid bifurcation and X2 at the cricoid cartilage. We then performed statistical analysis in SPSS. First, let's look at the left vagus nerve. There was no significant difference found in CSA between the COVID group and the controls at both sides of measurement. However, we could notice a trend toward enlargement in the COVID group. Right vagus nerve is where things got interesting. There was nearly 2 times higher CSA in COVID group compared to the patients at X1 and X2 place of the measurement. And also, now is the moment when I remind you that the patients were older than the controls in our study, because in older individuals, we would normally expect to see smaller nerve dimensions due to degeneration of nerve fibers. However, in our study, we discovered the opposite, but it actually only strengthened our beliefs that there was indeed a vagus nerve neuropathy present in SARS-CoV-2 patients. It likely led to a cytokine storm and severe clinical manifestations. Ultrasound has proven to be a useful method for detecting those changes. However, the implications of those findings go far beyond COVID-19, as the same inflammatory reflex and vagal dysfunction are key processes to many diseases, such as atherosclerosis, diabetes, autoimmune thyroiditis, inflammatory bowel disease. And these results are important because they could serve as a starting point for future research and development of new strategic therapies for those conditions. So, if there's one thing we've learned from the pandemic, is that science and medicine should always look one step ahead, and that step might actually be the vagus nerve. I would like to thank my mentor, Professor Olivera Jovanikic. We are currently doing a follow-up research on post-COVID patients. And if you're interested in seeing the full abstract references or my portfolio, you can simply scan the QR code on the screen. Thank you for your attention. I'm open to any questions.
Thank you so much for that excellent presentation, Ms. Michik. So we'll now open the floor for questions from our judges.
Okay, thank you very much, Ms. Michik. Is it okay for me to go ahead and start with the questions?
Yes.
Yeah, very interesting presentation. I have a question related to the controls. How did you decide on appropriate controls for this study?
Thank you for your question. In our study, it was quite difficult to find the controls, and they were medical students from my faculty. So they're healthy volunteers with a mean age of 22 years. And I'm sure that this is indeed a limitation of our study, but we tried to make it equal and to find the most appropriate group for this research.
Okay, so were they checked in terms of COVID positivity?
Yes, they were checked and they were negative.
Right, so you mentioned some confounders that could have impacted your results, and I was just wondering if any of that assessment was made in terms of your patient group.
Sorry, can you repeat?
You mentioned some confounders that can also affect vagal activity and cause degeneration in the nerve.
Yes.
So I was just wondering if those assessments were made among your patients, whether they had any of those confounders.
Yes, we had an exclusion criteria for everyone, and we wanted to check whether the vagus nerve was impaired in any other way. So we had to check for any autoimmune diseases, for chronic neuropathies, also for malignancies, in order to have the appropriate result.
Thank you so much. Very interesting. I look forward to more work. I suspect long COVID would probably be quite an exciting thing to look at.
Yes. Yes. Thank you so much.
Yes, Dr. Mukita, I think your volume's a little low. I can hear you a little bit. Miss Michik, can you hear her? Can you hear him?
Yeah, I don't hear her.
No worries. Yeah, I can hear you a little bit. So go ahead and ask your question and I'll repeat it. Oh yeah, I'm so sorry. That was quite hard to hear. Do you mind just like typing it in the chat and we can repeat your question and then we can move on to Dr. Fernando to ask the question? Dr. Fernando, I think you're muted. We can't hear your volume. May you try again? We can see that you're talking. You can also, yeah, go ahead and use the chat to type the question. No worries. We can hear you too, Dr. Mukita. Go ahead and use the chat to type in the questions.
For the judges, it will be on the right side of your screen. Just click on the private chat option and type in your question and we will repeat it. For the interest of time, okay?
Okay,
Okay, I'm gonna have you read them, Elaine.
Okay, sounds good. So Dr. Fernando's question is, ultrasound is not the most common first-line tool for assessing neuropathy. What was the specific advantage of using ultrasound over other neurophysiological studies like EMG, NCS in the context of post-COVID vagus nerve evaluation?
Okay, thank you, doctor. It was really a pleasure to get this question from you. So ultrasound is an accessible tool, and also it was really useful for us because we measured the cross-sectional area during the acute inflammation and disease. So it was pretty easy to get the results in this way. And also I could learn ultrasound methods easily from my mentor and take a part in this study actively. We are currently doing post-COVID vagus nerve evaluations as well, and we are planning on including EMG and also including nerve function examination, for example, heart rate variability test, and it is currently in the making. If that answers your question. Okay. And
okay. Thank you so much. So for the next question by Dr. Mukita, in her study, she has found right side vagus nerve has significant results so whether or not you have a significant result between the case and the control group and whether or not you checked which lung was affected more.
Yes, I found only the significant difference in the right side. However, we could see an enlargement in the left vagus nerve as well. We didn't exactly check which lung is more affected, but thank you for your suggestion. Especially we were thinking about why those changes were more prominently expressed in the right side, and that could potentially be due to anatomical difference in those pathways of those nerves. And for example, right vagus nerve predominantly innervates the sinoatrial node, and we thought that might be the reason why it is more affected in those inflammatory conditions, systematic inflammatory conditions.
Thank you. And also one more quick question by Dr. Mukita. Is there any study where other respiratory diseases affect the vagus nerve function?
Yes, there is, and I've mentioned it in my references. If you scan the QR code on my last slide, and it is actually commonly affected in respiratory diseases.
Okay, thank you so much, Ms. Michik.
Yes,
and thank you so much, judges, for your questions. Please, judges, feel free to take this transition time to submit your judging response form. We will now be displaying a QR code for audience voting. So please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during tomorrow's ceremony. So please don't forget to participate. Thank you. Next, we will be moving on to our presenter, Dr. Harriet Fallon from the UK, presenting their original research entitled Characterization of Morphological Changes and Retinal Decay in a Retinal Degeneration Murine Model of Retinitis Pigmentosa.
Hi.
So whenever you are ready, please go ahead and share your screen and proceed.
Oh, hang on a second. Just making sure I can do it. Can you see my screen?
Yes, please
You
proceed.
can see my slides?
Yes.
Brilliant, amazing. Okay, so I'll start off. So hi everyone. I just want to start by thanking the journal for the opportunity to present today. So today I'm going to talk to you about my research, which is characterization of morphological changes in retinal decay in a retinal degeneration murine model of retinitis pigmentosa. So my name is Harriet Fallon. I'm currently a resident doctor from the UK, rotating in trauma and orthopedic surgery. My background is in complement and immunology, but I was really excited to be given this new opportunity to spend some time working in retinal stem cell research. And I would also like to thank the British Division for the International Academy of Pathology for funding my research project. So just as a little introduction, retinitis pigmentosa is an incurable retinal dystrophy that initially presents as loss of night vision in childhood and progresses to severe irreversible loss of vision in adult patients. So the RD10 mouse models a progressive retinal degeneration akin to retinitis pigmentosa seen in humans, where photoreceptors degenerate very quickly. So retinitis pigmentosa is currently without cure. However, one such idea for successful vision restoration relies on the intraocular injection of hematopoietic stem cells as rod and cone precursor photoreceptor cells. So early transplantation of differentiated photoreceptors could delay or even prevent remodeling of the retina by providing synaptic input to those downstream circuits. But it needs to be early enough in the disease process, and enough retinal cells need to remain for them to be integrated and become functional. So thinking about this in terms of human illness, treatment interventions only really needed when the patient's symptomatic, but it needs to be not so severe that it can't be treated. So this is what my study tackles. It's to determine peak treatment need, but also sufficient likelihood of treatment success as well. So this is where we started. So mouse retinas were taken from wild-type mice, that's normal mice, and then also the RD10 genetically mutated mice that would then lose their photoreceptors. So we dissected the retinas off the back of the scleral shell, froze them, and then sliced them into very thin cryo cross sections and mounted them on sides for staining. So the diagram at the top of the picture is the method for qualitative immunofluorescence. So our sections were incubated with primary and then fluorescent secondary antibodies specific to various cell structures, and images were stacked and then captured on an immunofluorescent microscope. So sections included the normal mouse and then also the genetically mutated mice from days 24 to days 200 years old. Hematoxylin and eosin stains shown at the bottom. This was done to visualize the outer nuclear layer that contains the photoreceptors. This is kind of similar to a Gram stain. So hematoxylin stains the nuclei of the retinal cells blue, and then to differentiate the cells, the eosin stains the extracellular matrix, cytoplasm, and other acidophilic cellular structures pink, so we can get quantitative results of the depth of the receptors per postnatal day. So the photoreceptor containing outer nuclear layer can be seen in our H&E staining at the top, and average thickness of this layer was measured. The graph shows the statistically significant deterioration of this thick, dark layer of cells across the postnatal days. So this is at the top, and most significantly between the wild type and day P24. That's postnatal day 24. In immunofluorescence, we can see at the bottom, we can see the staining across the postnatal days compared to the wild type. DAPI stains the nuclei of the cells blue, and then the green rhodopsin stains the outer segments of the photoreceptors. And these have normal size and morphology in the wild type, but are severely degenerated at P24, sorry. And then this is what we found is peak rod degeneration. So this correlates with the values from the quantitative H&E staining we can see at the top. And we sort of found that by P41, the remaining photoreceptors die, and we have very sparse rhodopsin staining here. So across both figures, the recoverant stains the photoreceptor cells red, and we'd expect to see immunostaining in abundance in the wild type again on the left, and we see a significant deterioration at day 24 as before. G0 alpha at the top and PKC alpha at the bottom stain second order bipolar cells green. So second and third order bipolar cells sort of like they synapse with the photoreceptors and provide the cellular scaffolding that sort of keeps the retina intact. And then the third order neuron synapse with the second order. So in the wild type, the bipolar dendrites are in direct contact with the they're in direct contact with sort of like the photoreceptors and the outer plexiform layer. And then by day 24, fewer dendrites are in contact with and then penetrate upwards into the photoreceptors and the OPL. We find that the second order neuronal cellular scaffolding lags behind the photoreceptor cells and their death and their sort of degeneration. And that sort of is due to the reduction in synaptic input from these cells, meaning that, you know, despite significant visual and cellular degeneration at this day, there could still be scope for transplanted cell integration. So Bassoon and PSD95, both in green here, show the synapses between the photoreceptors and horizontal and bipolar cells in the outer plexiform layer and between the bipolar and ganglion cells in the inner plexiform layer. So both are plentiful in the wild type again, but are completely absent at varying speeds by P150. Only intensity in the IPL is preserved as this layer doesn't interact with the photoreceptors, just like the OPL does. So similarly, chat in the white shows the amacrine cells in the INL and the ganglion cell layer. There's no changes in immune activity across postnatal days, and these are largely preserved in disease progression due to their separation from the photoreceptor cell layer. And these can be used as somewhat of a control, and also proves that the RD10 mouse very closely models the disease progression of retinitis pigmentosa in humans. This is further emphasizing the potential application of these results too. So cal-binding in red stains the second order horizontal cells across both the figures, which line the top of the inner nuclear layer. And again, peak red fluorescence is at wild type and P24, from which day the horizontal cell plexus gets progressively thinner due to degradation of its upward synaptic connections and thus atrophy of those cells, as also evidenced by the decrease in green. So this is just sort of all of our work together. I just put it because it's pretty and very proud of it as well. Together, these stainings show that whilst the basal cell architecture remains up until quite late postnatal days, there is significant early degeneration in second order neuron and synapses staining. So this work is part of a larger study where we're growing retinal organoids from stem cells via tissue culture to create photoreceptors to inject into blind mouse retinas, and vision restoration is measured via a series of light-controlled studies. This study helps to inform the optimum timeline for the intraocular injection and transplantation of hematopoietic stem cells, and then thus the replacement of degenerated photoreceptors, ultimately for the potential restoration of vision in retinitis pigmentosa. We've shown that whilst the most significant degeneration of photoreceptors and thus vision is at P24, which is the optimum postnatal day to attempt reintegration of sight-seeing cells in the lab, perhaps even up to around P45, could there be the possibility of restoration of lost vision? So this extra time is more important when considering the possibility of future human studies and actual human population, many of whom will not be able to attend for timely intervention as soon as sight begins to deteriorate, especially in those areas with poor access to healthcare. So the successful propagation of this study could be revolutionary and could eventually inform the treatment for blindness in retinitis pigmentosa patients. Thank you for listening. I would just like to thank the following colleagues and groups, and I'm happy to take any questions. So I'm going to try and come back onto the screen here as well.
Thank you so much, Dr. Fallon. So we will now be opening the floor for questions from our judges.
Okay, thanks, Dr. Fallon. Very interesting work, nice animal studies in terms of the results. I'm really impressed with what you're showing and looking forward to the translation in terms of human health. In terms of your statistics, I don't think I saw the numbers. And my question relates to what number of retina were involved and what statistical test did you use in terms of the inferential statistical results?
So was that how many sort of mice were involved there? So it was quite a big study that we did. So we have in our university, we have sort of like a almost library of mice downstairs where we sort of like grow them to specific postnatal days. But we sort of like will take those mice and we will have to, when we go through our cryosections, we're very particular about the ones that we want to have. We don't want anything that's too far on the peripheries of the eye or anything like that. We sort of want it to be right in the middle. We have, I would say, involved in the study, we had maybe this particular one, I'd say we did about 5 mice per postnatal day. And then we took loads and loads of the images on our fluorescence camera, and we did pick the ones that looked the best, because you can have really like sort of like weird stainings that don't sort of like come out right or anything like that. So we're probably about 5 per one, and then all the photos that we took and all the stainings that we took of all those mice, they all seemed to sort of like say very, very similar things as well. So we'd see the same stainings in each of those 5 mice. And then when we were making our infographics, we sort of like put the ones that would be able to label the easiest and sort of like, you know, put in and will look the best, just to sort of like as anything would, like that really.
Okay, and so what inferential statistics did you use in terms of those p-values that you showed us?
Oh, I mean, you'll have to forgive me. This was a couple of months ago, and this was so I've completely forgotten which ones I've done. I've always been really bad at statistics, so it's sort of like completely dropped my mind. It's like, you know, when you learn something and it's short-term memory, but it was just really what the point of it was that we were comparing, was that we just wanted to make sure that it actually was a significant drop in the outer nuclear layer we were using. So we didn't want it to be sort of like, well, we've taken a wrong section from somewhere and, you know, that's been part of the data. We just wanted to make sure that, you know, the mean average that we were taking from everything was significant in terms of like, this is an actual big drop that we saw in the length of the outer nuclear layer.
And those things are kind of important, you know, because whether you should be using students' t-tests or man Whitney's, it's critical. Your selection method does sound a little bit iffy. It sounds, yes, you want to remove the outliers, but it looks like you went with the prettiest off. So just some queries there in terms of the selection and actual statistics used. But I'm very excited about the work and translation in terms of patient care. Thank you.
All right, thank you so much, Professor Gozo Williams. So now we'll be moving on to the additional questions. So our first question is by Dr. Mukita. He asks, what are the infectious agents of retinitis pigmentosa, and what is the limitation of your study, beyond the ones that you've already mentioned?
So in terms of infectious agents, I'm not entirely too sure. It's sort of like an inherited condition that we see. And I suppose, you know, there could be sort of elements when we move into human population, especially worldwide, whether, you know, you have specific infection agents that are sort of like interacting with the retina at the back. But in our study, we were very particular about how we kept our mice. So we kept infection to a minimum. We had sort of like biological showers and things that we would use. Everything would be completely covered up. Like there's minimal infection risk. And all of our mice were like clean mice. So if anything were to occur like that in human population, it sort of wasn't within our study. And I suppose that could be a limitation of it in itself. So when you're doing this sort of like animal research, it's very, very contained in like you are only looking at this one specific thing. There's one very, very controlled environment. So that's a limitation in itself, I suppose. And then further, I think a lot of the limitation is, I suppose, a lot of the sections that we did use, sort of like as you're cutting with the machine, like a lot of them can come out sort of like not very like neat. So a lot of our sections just aren't usable. But, you know, there are sort of things that we did address. So we made sure to use like, you know, an equal amount of like male and female mice. And we were very specific about sort of like the postnatal days we used. And we made sure that they were sort of like kept healthy and they had daily checks on the mice. So we tried to keep the variables to a minimum as far as we could. But I suppose limitation of the study is that you don't know how it's going to translate into human populations, which I suppose is akin to the infection agents that you mentioned in your question.
Thank you so much. And from Dr. Fernando, she asks, what do you believe is the most significant challenge in directly translating these pathological findings to the human experience of retinitis pigmentosa?
It's a good question. So I suppose, again, it's a different species, I suppose, isn't it, in that sense? And I think it's tricky. If we did go to sort of like human studies, I suppose that people are able to communicate better about specific changes in their vision. With mice, the way we were sort of like analyzing loss of vision was just by light controlled studies, and they obviously have sort of like animal behavior in itself mixed into that. So there are going to be, you know, lots and lots of false positives, false negatives, things like that. But I suppose just like there's a lot more steps yet to go. So I think that's the most difficult part of it. Like there are so many more things we have to specifically get correct. We have to make sure that the organoids are all growing properly. And, you know, everyone knows that tissue culture is really like formidable in terms of it can go wrong so easily. And then sort of like making sure that we're able to be precise enough to inject at the right point in sort of my size and things like just lots of human error can be involved in it as well. And I think that's sort of been one of the most significant challenges, just making sure we actually get to the end of it. There's so many hoops to jump through still, I suppose. I'd probably say that.
Thank you so much for answering the questions, and thank you so much, judges, for your questions. Now we will be moving on to audience voting. So we will now display a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. And judges, please feel free to take this transition time to submit your judging response form as well. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Now we'll be moving on to our next presenter, Miss Maria Palfi from Romania, who will be presenting her case report on subcutaneous panniculitis-like T-cell non-Hodgkin lymphoma associated with Cushing syndrome and introspection.
Hello.
Hi, we can hear you. Thank you so much, Miss Palfi. So go ahead and share your screen and please proceed.
Okay, thank you. My name is Maria Palfi and I'm a fourth year medical student at the Iuliu Hațeganu University of Medicine and Pharmacy from Cluj-Napoca, Romania. Today I have the pleasure of presenting the work conducted by my co-authors Alexandra Zirbo, Cristina Simian, David Kegeș, Ana Maria Bancos, Ciprian Tomuleasa, and myself, entitled Subcutaneous Panniculitis-like T-cell non-Hodgkin lymphoma associated with Cushing syndrome and introspection. Next slide, please. I would like to begin by introducing the terms and concepts I will be discussing today as follows. Subcutaneous panniculitis-like T-cell lymphoma accounts for less than 1% of non-Hodgkin lymphoma cases and is characterized by malignant lymphocyte infiltration into adipose tissues. The term panniculitis-like T cells refers to the histological similarity of the lymphoma cells to the C cells found in chronic or granulomatous panniculitis. This type of lymphoma is responsible for an ectopic ACTH secretion, which leads to excessive cortisol secretion, causing Cushing syndrome. Next slide, please. Histological identification plays a crucial role in understanding the particularities of this diagnosis. The disease is defined by pleomorphic malignant T-cell infiltration within the subcutaneous adipose tissues, accompanied by numerous macrophages while sparing the dermis and epidermis. The infiltrate is primarily lobular in distribution with no or occasional septal involvement, shown in picture A, which is a hematoxylin and eosin stained section of a punch biopsy of a skin lesion from the right upper arm of a patient with deep subcutaneous nodules. It shows infiltration of the deep subcutis involving mainly the lobular fat and highlighting the characteristic rimming of atypical lymphoid cells around the fat spaces, shown by the arrowhead. Immunohistochemically, the atypical lymphoid cells are positive for CD2, CD3, CD7, CD8, beta F1 and activated cytotoxic proteins, T-cell intracellular antigen, granzyme B, and or perforin. Negative for CD4 as shown in picture B, and negative for CD56 and CD30. Next slide, please. Now we will progress with from the general background to the detailed analysis of our case. The 45-year-old female patient known to have drug-induced Cushing syndrome and a hematologic diagnosis of T-cell panniculitis-like non-Hodgkin lymphoma established in March 2022 was admitted to the hospital with scleral jaundice, slightly darkened urine, which had appeared approximately 2 and 5 days earlier respectively. In her medical history, the patient had presented with hemophagocytic syndrome associated with coagulation disorders and pulmonary thromboembolism. For her hematologic condition, she had received to date 6 cycles of cyclophosphamide, epirubicin, vincristine, and prednisone, known as CHOP regimen. Due to iatrogenic Cushing syndrome, CHOP was discontinued, and 2 cycles of rituximab, iofosfamide, carboplatin, and etoposide, or known as RICE, were administered. Upon clinical examination, the patient presented with mildly jaundiced skin and scleral subicterus with no palpable peripheral lymphadenopathy. The stools were slightly pale, and the patient reported spontaneous urine with dark-colored urine. Next slide, please. To complete the clinical assessment and reach a conclusion vis-à-vis the course of treatment, paraclinical investigations put everything into context. Laboratory findings showed leukocytes at the lower limit of normal hemoglobin, macrocytosis, slightly decreased platelet count, marked hepatocytolysis, cholestasis, hypokalemia, mildly prolonged INR, elevated fibrinogen, and slightly increased D-dimers. CT findings revealed a subcentimetric hepatic lesion, a lesion involving the iliopsoas muscles, indicating systemic dissemination and relapse of the lymphoma, and no biliary tract obstruction or compression. Next slide. These findings lead to a series of discussions and ultimately a conclusion. Corticosteroid-based regimens are standard treatment options for CPT-CL. However, paraneoplastic syndrome such as ectopic ACTH secretion by malignant cells may lead to excessive cortisol levels exacerbated by corticosteroids. Due to iatrogenic Cushing syndrome induced by the first-line therapy and relapse following second-line options, off-label venetoclax, an apoptosis inducer, was initiated in combination with ropeg interferon alpha-2b. The patient achieved complete remission. No CPT-CL cases treated with venetoclax have been published in the literature. We report high efficacy of off-label venetoclax for relapse CPT-CL with no other therapeutic option. Next slide. I attached the citations of the sources I used, and next slide. With that, I have reached the end of my presentation. Thank you for your time.
Thank you so much for your presentation, Ms. Palfi. So now we will open the floor for questions from our judges.
Okay, thanks, Ms. Palfi. Elaine, I just wondered if one of our other judges wanted to start and didn't want to be taking up all of the show.
Yeah, sure, of course. So we did have a question from Dr. Mukita. He asked, is there any difference in the treatment if there is no presentation of non-Hodgkin lymphoma?
Well, yes, because the rice and the chop regimens were administered because there was a case of lymphoma. So if that's not the case, the treatment changes. The main aim of this case report is to see that venetoclax is a viable off-label option for a relapse of CPTCL.
Thanks, Miss Palfield. I was very intrigued by your project. I do have a particular interest in adverse drug reactions, so I really found this interesting. I was just wondering, you did mention a number of proteins that you were probing, CD2, CB3, or CD7. I don't think you actually measured them, but I was just curious as to the potential of any of these as biomarkers to offer some kind of trigger, or some screening to offer protection, for patients.
Yes, it can be an option, especially the histological identification. So taking a biopsy from subcutaneous nodules was that, and that can be an option.
Yeah, biopsies are so invasive. I was just wondering if there was any quicker biomarker, it's a trigger to doctors in terms of, hey, something's happening here. We need to revisit the patient's treatment.
Yes, that would be a better option, but I do not know if there are reports of a better option in the literature, because as you saw in my case, in our patient's case, a relapse was discovered by accident because the patient came to the ER presenting totally different symptoms from what you did expect from someone with lymphoma, and a CT scan was performed, and the relapse was discovered by chance.
Thank you so much.
Thank you. And last question by Dr. Fernando. She asks, what was the single most crucial piece of evidence, clinical, histological, or laboratory, that definitively steered the diagnosis towards lymphoma?
The most definitive was the CT scan, but I'm not referring to the CT scan we did to catch the relapse. I'm referring to the CT scan that was made in 2022 when the diagnosis was placed, the diagnosis of CPTCL. And a second CT was performed in 2023 by the ER crew, and that is how we discovered the relapse.
Thank you so much. And thank you, judges, for your questions. Judges, please feel free to take this transition time to submit your judging response. And we will now display a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. And now we will be moving on to our next presenter, Dr. Bashir Babaa, who is now presenting another case report on primary intestinal lymphangiectasia, presenting as chylous ascites in a young female, a rare case. So whenever you're ready, Dr. Babaa.
Yes, I'm ready. So hello once again, and thank you for making things easier for me and sharing the slides. Again, this is Bashir Babaa. I am delighted to present the second case titled Primary Intestinal Lymphangiectasia, presenting as chylous ascites in a young female, a rare case. Next. So I would refer to our disease with the abbreviation PIL now onward. So it is a rare condition that occurs primarily due to pathological dilation of lacteals or of intestinal lymphatics, leading to protein losing in neuropathy. It occurs more commonly in children, whereas adults' occurrence is exceptionally rare. For example, in my hometown, Palestine, after a systematic search of databases, this case represents the first ever case of adult onset PIL in Palestine. What makes things much more challenging is that the overlapping features with other differential diagnoses such as celiac and Crohn's disease makes PIL posing a significant diagnostic challenge. Next, please. Our patient is a 28-year-old female presented with recurrent abdominal distension and callus ascites over the past 3 years. However, its history started much earlier, approximately 7 years ago, with crampy recurrent abdominal pain, diffuse but more in the periumbilical and right lower quadrant. Associated features include bloating, loose stools, and weight loss. Next. With that being said, the initial suspicion was focused on Crohn's disease. However, colonoscopy and histopathology showed no supportive findings of such a presumptive diagnosis. Despite this, the patient was briefly treated as a case of a Crohn's disease. Unfortunately, the patient did not respond well to treatment, and the new onset callus ascites prompted reconsideration of the diagnosis. Next, please. The patient denied fever, night sweats, diarrhea, or overt GI bleeding. On physical examination, the abdomen was distended with a positive shifting dullness, but there were no peripheral edema, lymphadenopathy, or hepatosplenomegaly. Next, please. Going to labs, there were low hypoalbuminemia, ascitic fluid, turned back sterile, and negative for malignant cells. A PET CT scan was ordered to exclude occult malignancy or secondary causes of PIL. Next, please. Here is a PET CT scan demonstrating diffuse FDG uptake in the small intestine, jejunum, ileum, ascending colon, and proximal transverse colon, consistent with hypermetabolic bowel wall thickening. No discrete focal lesions or metabolically active lymphadenopathy was identified. Next, please. Going on, CT scan of the abdomen showed diffuse thickening of hepatic flexure of the colon, mesenteric fat stranding, lymphadenopathy, and moderate volume ascites. Clinical features plus radiologic features raise the suspicion of lymphatic telangiectasia. Next, please. On endoscopy, these white blacks seen in the right side of the image showed or suggest a lymphatic dilation. These mucosal changes were most prominent in the second part of the duodenum and raised initial concern for infiltrative or lymphatic pathology. Next, please. What eventually clinches the right diagnosis is the histopathologic examination of the small intestine. It showed preserved villus architecture with dilated intestinal lymphatics, and other secondary causes were excluded also. I mean, there were no parasites, granulomas, metaplasia, dysplasia, or malignancy. Next, please. Regarding management, besides the cornerstone of management which is diet, the patient was educated to maintain a high protein, low fat diet and started on budesonide and long-acting octreotide. Fortunately, this time the patient showed a clinical improvement, decreased abdominal distension, and reduced need for therapeutic paracentesis. Next, please. The previous one. One more slide, previous. Key insights regarding our case is that adult onset BIL is rare and overlaps with other differential diagnoses, making it difficult to diagnose. The diagnosis eventually required histopathologic confirmation and exclusion of secondary causes. And dietary modification remains the cornerstone of therapy, and other therapies I mentioned are reserved for refractory cases. Next, please. Now, broader implications is that this case highlights major knowledge gaps in diagnosis and managing adult onset PIL. Lack of standardized tools to measure lymphatic dysfunction limits disease monitoring and disease progression. Limits monitoring the disease progression, sorry. Adult presentations remain poorly characterized, emphasizing the need for individualized care. And ongoing research is still needed to clarify the natural history, identify pathologic mechanisms, and develop targeted personalized treatments. Next, please. And here is the thank you slide. Thank you for your attention.
Thank you so much, Dr. Babaa. So now we will be opening the floor for questions from our judges.
Thank you, Dr. Babaa. Very interesting case. And these rare cases can pose a significant challenge to clinical practice. So my question really relates to how does this inform clinical practice for you and probably your hospital in terms of these kind of presentations?
Thank you for asking this question. Because it is rare, me and any other physician would not put this diagnosis at the top of the differential, but at least after encountering such a case, we need to put this differential diagnosis at the back of our mind and looking for it anytime the patient do not respond to treatment of other differential diagnoses.
Right. Thank you so much for your response.
Thank you so much, Dr. Gossel-Williams. So now we have a question from Dr. Fernando, and she asks, what is the long-term management strategy for this patient? And what are the primary nutritional concerns you need to address to prevent complications like protein losing and enteropathy?
Thank you for asking this question. The treatment regimen regarding diet, we educated the patient to take or to follow a high protein diet to replenish the protein loss. And due to fat malabsorption, we recommended the patient to take a low-fat diet, and this is the long term and the cornerstone of management. Other treatment may be used if there are relapses.
Thank you so much. And for the next question by Dr. Mukita, he asks, so in your case, the disease starts so early but is diagnosed very late. Why is histopathology not performed earlier, and whether or not you did a root cause analysis?
Very interesting question. I think the single most important notion or point that make the diagnosis later is that the disease is pretty uncommon. So we did not put it at the differential diagnosis early on the disease course, and we only put it in the differential when things get worse. So the scarcity of cases, what makes it diagnosed later on.
Okay, thank you so much for your presentation and also for the questions from our judges. So judges, please feel free to take this transition time to submit your judging response form. We will now display a QR code for audience voting. So please go ahead and scan the QR code on the screen to vote for your favorite presentation.
All right, let me put it up. Okay.
Thanks, Anna. So go ahead and vote using the QR code on the screen for your favorite presentation. Your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Our next presenter, Mr. Victor Rivero from Guatemala, who presents his original research entitled Sleep Quality in First to Third Year Medical Students at Universidad de San Carlos de Guatemala, Prevalence and Associations with Daytime Sleepiness and Perceived Stress. Whenever you're ready, Mr. Rivero, go ahead and share your screen and proceed.
Thank you very much. So hello, everyone. My name is Victor Rivero, and I am a fourth-year medical student from Universidad de San Carlos de Guatemala, the only public university in the country, the oldest in Central America, and one of the 4 oldest in the Americas. I am deeply interested in how medical education shapes not only what we know, but who we become as human beings. And one of the most powerful, yet often ignored forces that shapes us is sleep. It all started with a simple question we've all heard, sometimes maybe as a joke. Are we medical students truly sleep deprived, or do we just share a crybaby complex? Here in Guatemala, it's common to hear students joke about how much we suffer in medical school. We talk about medicine all day, and our friends can get tired of hearing it, right? They tease us, saying, "Oh, you study medicine, right? Of course you don't sleep." And sometimes we even laugh and agree. But I started noticing something. Everyone looked exhausted. We were irritable, distracted, and many admitted they didn't even remember what they studied the night before. So I began to wonder, are medical students at my university sleeping enough? Is poor sleep really linked to daytime sleepiness, or are classes just that boring? And does the way we sleep affect how much stress we feel every day? Well, we found no previous reports examining sleep quality and its associations with daytime sleepiness and perceived stress among Guatemalan medical students. Therefore, we designed a study to test exactly these points, representing an initial contribution to this field. Our main objective was to determine the prevalence of poor sleep quality among first to third year medical students at Universidad San Carlos de Guatemala, and to evaluate its association with daytime sleepiness and perceived stress. In other words, we wanted to understand how our sleep, our stress, and our daily functioning were connected. So, we conducted a cross-sectional online survey between June and July 2024. Participants completed 3 standardized instruments: the Pittsburgh Sleep Quality Index, where scores greater than 5 indicate poor sleep quality; the Epworth Sleepiness Scale, where scores of 10 or more indicate excessive daytime sleepiness; and the Spanish version of the Perceived Stress Scale, where scores of 27 to 40 reflect high perceived stress. We also collected some demographic data, such as age, sex, and academic year. Associations were analyzed using chi-squares tests for categorical variables and Spearman correlations for continuous ones, with a significance level of 0.05 analyzed in our software. In our study, we included 100 students. 61% of them were women, with a mean age of 21.7 years. All participants were preclinical, between the first and third year of medical school. That means before starting hospital rotations. To our knowledge, this is the first study to assess sleep quality and stress among Guatemalan medical students. Here's what we found. On average, students reported sleeping just under 5 hours per night. And the most common answer to how many hours do you sleep was simply 5. 90% of students had poor sleep quality. Almost half of them had excessive daytime sleepiness, meaning they were at risk of falling asleep in class, while studying, or even while driving, which is especially dangerous in Guatemala, where spending 2 hours in traffic for a 30-minute commute is not unusual. Additionally, nearly 9 out of 10 reported high perceived stress. As you can see from this figure, our results clearly illustrate the extent of the problem. These numbers are not just statistics. They paint a clear picture of a student population struggling with their well-being due to sleep deprivation and high stress levels. Significantly, poor sleep quality was not associated with a student's sex nor their academic year. This suggests that poor sleep is a problem affecting all preclinical students equally, regardless of their sex or how long they have been in medical school. And statistically, sleep quality correlated positively with both stress and daytime sleepiness. This means the worse you sleep, the more stressed and drowsy you feel. So yes, the crybaby complex was not a myth. We are, in fact, not sleeping. But this is not only about being tired. It's about the hidden cost of chronic sleep restriction on learning, empathy, and mental health. Medical education, especially in low and middle-income countries, often normalizes exhaustion as a sign of commitment. We learn to function under fatigue, but we also learn to ignore our own needs. Something that can later affect how we treat patients, colleagues, and ourselves. Our findings suggest that structural factors like schedules, workload, and institutional culture are not only academic challenges, they are public health issues inside medical school. We, the medical students, the future doctors, need to remember that behind every white coat, there's a human being who also needs rest and compassion, starting with self-compassion. Taking care of our patients begins with taking care of ourselves. And while these results cannot be statistically extrapolated to other populations, I believe the human lesson applies everywhere. For institutions, this means promoting sleep hygiene education, flexible schedules, and stress management programs. For students, it means realizing that sleep is not weakness, it is wisdom. Thank you very much, and I dedicate this work to all my classmates who study medicine by day and survive it by night. Thank you.
Thank you so much for the wonderful presentation, Mr. Rivero. So now we will be opening the floor for questions from our judges.
Hey, Dr. Rivero, Mr. Rivero, I'm speaking it into being. What year of medical school are you in again, please?
I'm in Universidad de San Carlos de Guatemala. Yeah.
All right, great. So I'm appreciative of the fact that you indicated that it's not generalizable to all population in Guatemala. So this was really in one medical school. You sampled 100, so I'm concerned in terms of how representative is it of your school? How many students do you actually have in your school, and how did you ensure that it was that 100 was a true representation of your school?
So we actually, in the preclinical years, have approximately maybe 2,000 students, but not everyone had access to this particular study, and it was by convenience. I posted a lot of messages, a lot of posts about the survey, and then only the ones who got the survey got the chance to do it. But it was balanced between first, second, and third year. It was almost 33% in every gap. Yes.
So we can agree that because it's convenient sampling, it may not actually represent your school.
Right. So this is maybe a pilot study. We're working on a second study measuring also empathy with the Jefferson Empathy Score, so that we can reassure that these results really mean that students are really affected, right? But yeah, this is like a little study, yes.
Wonderful. And I'm glad that you mentioned the term pilot study, because yes, you've used a number of questionnaires, sleep questionnaires that are used quite extensively in other populations. But was there any validation of these in your Guatemala group? And in other words, did you do any pilot study of the questionnaires in terms of their suitability for your population?
No, I did not. I did not do a pilot study.
All right. So that's, it's a limitation. So just, in case you're planning to publish this, and I think it would be important to publish, those are limitations you'll need to mention in terms of your sampling and whether the fact that you didn't really pilot test your questionnaires. Thank you.
Yeah, thank you very much.
Thank you very much, Dr. Agasa-Williams. So next, Dr. Fernando has another question. She asks, how did your research design attempt to address the question of causality? For instance, could perceived stress be a cause or a consequence of poor sleep?
Right. So my study wanted to describe the association, but finding what comes first, like the egg of the chicken, that's really difficult, right? I don't know what's the causality of it. That wasn't like in the aim of the study, but we know it is associated. I mean, with the data we have and the methodology we used, it is not possible. I understand it's not possible to understand or to say what comes first, but it is in this study evident that these three things are related. But I don't know how to respond to which comes first. Yeah.
Thank you. And from Dr. Mukita, he asks, have you validated your questionnaire?
I'm sorry, Elaine, I cannot hear you. I'm sorry.
Yeah, I'll repeat again. Can you hear me now?
No.
Can you hear me now? Okay. Hey. Can you hear me now? No.
No, but I can see the chat. And is it the question about the validation of the questionnaire?
Correct.
Oh, okay. Yeah. So I think I responded that question with the previous question, but no, since this is the first study made in Guatemala by our understanding, this is the pilot study, right? We wanted to answer these questions before, but yes, validation of the questionnaire in our particular population, meaning Guatemala, is pending. However, in the design of the study, I made sure that other studies had been made in a similar context in Latin American countries, right? For example, Colombia had one study that used the Pittsburgh Sleep Quality Index, or also Mexico. There was also a multicentric, very big study in Latin America that used the Pittsburgh Quality Index study. So I made sure that although there are not like current big studies testing this particular questionnaires, I made sure that they were already published in other populations similar to Guatemalan. Mm-hmm.
All right, thank you so much, Mr. Rivero. And now we will be moving on to displaying the QR code for audience voting. So thank you, judges, for your questions. Please feel free to take this transition time to submit your judging response form. Go ahead and scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Okay, so now we will be going on to our next presentation by Dr. Irina Maria Russo from Romania, who presents her case report entitled Amyloidosis, a rare complication of long-evolving rheumatoid arthritis, a case report. So, Dr. Russo, whenever you're ready, go ahead and share your screen and please proceed.
Hello everyone, my name is Irina Rusu and I'm a medical student in Cluj-Napoca, Romania, and today I'm going to present a case of a rare complication of rheumatoid arthritis, which is amyloidosis. To begin with, amyloidosis refers to a spectrum of diseases with the unifying characteristic of progressive accumulation of misfolded proteins in various tissues. There are several types of amyloidosis, out of which the most common is amyloid light chain or AL amyloidosis. It is a primary form of the disease, while secondary amyloidosis or amyloid A protein, so AA amyloidosis, develops secondary to chronic inflammatory diseases. Both forms of the disease are rare, with only a few cases per million per year. And AA amyloidosis mainly occurs due to overproduction of one acute phase protein, which is serum amyloid A or SAA, which forms in response to long-term inflammation. Clinically, due to the fact that amyloid can deposit in various number of tissues, amyloidosis can present with different organ dysfunctions. The most frequent are heart failure with preserved ejection fraction, affected kidney function with proteinuria or renal failure, neuropathy, and several gastrointestinal or hepatic manifestations. So AA amyloidosis has been linked to a number of chronic inflammatory diseases, but rheumatoid arthritis, or RA, is the leading cause in developed countries. Incidence in RA patients is not very well determined as of yet, with estimations between 5 to 26%. And AA amyloidosis mostly develops in these patients due to significantly higher levels of SA, which have been documented. And interestingly, duration of disease activity might be more important to the development of amyloidosis than severity of disease. So our patient is a 55-year-old female with a medical history of seropositive rheumatoid arthritis diagnosed in 2010. It has been initially controlled with methotrexate for 3 years, which was discontinued due to digestive intolerance, and she has been taking sulfasalazine ever since. At the current presentation, she complained of inflammatory hand arthralgia with morning stiffness, persistent asthenia and fatigability, and pruritus, and her physical examination revealed swollen metacarpal and radiocarpal joints, positive Gansen sign, and hyperpigmentation on forearms and hands, which you can see in the figure below. As for her lab results, she has been showing very important inflammatory syndrome ever since 2024, with extremely high values for both CRP and ESR. So after excluding infections and malignancies, the suspicion of secondary amyloidosis was raised and follow-up laboratory tests were performed, out of which serum light chains showed slightly elevated values. However, serum protein electrophoresis with immunofixation was negative for all monoclonal bands. Her organ involvement assessment showed no significant modifications. Most importantly, no proteinuria was present, and SAA protein levels were high, and they will be regularly monitored in the follow-up. So the next step in the diagnostic process was an abdominal fat tissue biopsy, which on histopathological examination was positive for Congo red stain under polarized light, which is the characteristic modification for amyloidosis, and therefore the diagnosis of AA amyloidosis secondary to rheumatoid arthritis was established. She was switched to leflunomide until we can finish the evaluations for her to be included in the national program for biological therapies. So the differential diagnosis between AL and AA amyloidosis in RA patients is very important. Firstly, due to the fact that the AL form has a faster tendency towards degradation of organ function, and treatment has specific treatment, some forms of chemotherapy and immunotherapy, while for AA amyloidosis, the main intervention is strict control of inflammation. Clinically, we can orient ourselves as AA amyloidosis most frequently affects the heart, which is rare in the AA form. The AA form primarily targets the kidney, and laboratory findings will differentiate between the two. We mentioned that for our patients, serum light chain levels were only slightly elevated, which is not concurrent for AL amyloidosis. Subclinical AA amyloidosis can be suspected in a patient with RA, who has been having a long-standing inflammatory syndrome, which contrasts with only mild clinical manifestations. Abdominal fat needle biopsy has been suggested as a screening method for this disease more and more in the last years. And due to the fact that strict inflammation control is the cornerstone of AA amyloidosis management, we should employ biological therapies whenever it is possible. Table 6 shows the biologic agents included in the EULAR guideline for RA. And we mentioned that, with the exception of golimumab, all have been reported to ameliorate AA amyloidosis manifestations, but only in case reports. To conclude, our case underscores the necessity of heightened clinical suspicion for AA amyloidosis in RA patients when they have been having persistently marked inflammatory syndrome, contrasting with mild symptomatology. Fat biopsy with Congo red staining is a reliable and considered minimally invasive screening method for this disease. And when diagnosis is made, switch to biological agents is very important in order to optimize inflammation control and therefore limit amyloid accumulation. These are my references. Thank you for your attention, and I am awaiting questions.
Thank you for that excellent presentation, Dr. Rusu. So now I'm opening up the floor for questions from our judges.
Thanks, Dr. Rusu. Very interesting case. A number of our presenters are looking into these, very minimal or presenting cases, and it really is very interesting work. I noticed that you're recommending the monoclonal antibodies, which overall are so expensive. I don't know how patients in low and middle income countries are going to afford that kind of direction, but we'll see. Maybe you'll encourage them to reduce the cost of those expensive medications. So my particular question relates to usefulness of biomarkers in terms of detection and screening. And there are quite a number of them that were measured in your patients. Any insight into possible biomarkers as part of the screening rather than going to the biopsy as your detection of the disorder?
So the fat biopsy, the fat aspiration biopsy, is currently considered to be more sensitive and specific for the detection of amyloidosis. In terms of AL amyloidosis, the serum light chains levels and also the electrophoresis is not that specific. There are certain types of, let's say, syndromes that are like multiple myeloma and so on, which can have raised levels. But however, SAA is quite good for AA amyloidosis, but the biopsy is still considered better for detection.
Thank you so much for your answer.
Thank you, Dr. Gossel-Williams. So next we'll be moving on to Dr. Mukita's question, and he asks, what is the definitive diagnosis and treatment of amyloidosis in RA?
So definitive diagnosis is put by the histopathological analysis. So if we see that apple green birefringence, we know that under polarized light, we know that amyloid is present. And then there's the question of which type of amyloidosis we have. So for this patient, because we had no significant, not that significant modifications on the serum light chains, we established that it must be secondary to the rheumatoid arthritis. And because of those very, very high levels of ESR, if you noticed, she had at some point above 90 ESR. So that those are strong enough arguments for establishing the diagnosis of AA amyloidosis. And in terms of treatment, there's a definite need to move on to biological therapies, and we will do so as quickly as possible.
Thank you so much. And the last question from Dr. Fernando. How did the diagnosis of secondary amyloidosis alter the overall management plan for this patient's RA?
So, as I said, in terms of treatment, moving on to biological therapies, but there's also a need for closer follow-ups, let's say. So we need to monitor, very closely monitor her, her renal function. She has had several admissions in the last few years, and at no point she showed proteinuria, which is in about 70% of cases present at diagnosis for AA amyloidosis. So we need to monitor her renal function in order to detect any kind of modification. And for the heart, it is less likely. The kidney needs to be monitored. But I think that with the biological treatment, which will be started at the end of the month, we hope there's no expected worsening of her state.
Thank you so much, Dr. Rusu. And thank you, judges, for your questions. Judges, please go ahead and take this transition time to submit your judging response form. And now we will be displaying a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's award ceremony. So please don't forget to participate. Thank you. Now we will be moving on to our next presenter, Dr. Juan Jose Velez Posada from Ecuador, presenting a case report entitled Left Colo-Renal Fistula in an Elderly Female Case Report.
Well, hello everyone, dear colleagues, presenters, and judge, and also the organizing committee. My name is Dr. Juan Velez. I'm medical doctor from Universidad de las Américas here in Quito, Ecuador. We wrote this case report with the help of Dr. Wilson Peñafiel, who is looking for us today, and it's important to mention it. And this case report is entitled Colo-Renal Fistula, Secondary to an Infected Renal Cyst, a rare case report. Well, what's important to know? First of all, colo-renal fistula are extremely rare entities and extremely rare conditions. There's not established any prevalence, but it's few cases reported worldwide. Despite this condition are unusually, They usually appear at the left side because of the proximity to the splenic flexure of the colon and the left kidney. There are common causes, of course, they are. The principal causes could be inflammation, necrosis, maybe trauma, infection, and also diverticulitis. The aim of this presentation is to show you a rare case of colo-renal fistula caused by a renal cyst. And also we want to highlight the diagnosis challenges and the surgical management in colo-renal fistulas. And also we want to emphasize the importance of the multidisciplinary approach in these cases. Well, we're going to start with the presentation of the patient. She was an 82-year-old female with history of diabetes, hypertension, and diverticulitis. It's important to mention that the patient suffered 3 months of history of left lumbar pain, and that's the reason why she came to Hospital Eugenio Espejo here in Ecuador. The urology team decided to make an imaging. We decided to make a CT urography, and we found a renal cyst. We classified that renal cyst as Bosniak 3. And we planned the patient for surgery, especially a cystectomy. Here we can see the Bosniak classification. The patient was classified as a Bosniak 3. As we can see, the imaging was an indeterminate imaging with multiple septations or thick septations and also mural nodules. The treatment is to make a partial nephrectomy, and that's why we decide to planify the patient for a lumbotomy, and then we're gonna decide to make the cystectomy because of the estimated malignant percentage of this renal cyst. But what happened? 15 days before the surgery, the patient suffered a fall on the left flank. That fall worsened the pain of the patient. The patient refers asthenia, well lost, and also it's important to mention that the patient refers pneumaturia and fecaluria. That change of symptoms make us to think the patient is not in a good condition. That's why we decide to make a CT scan and to repeat the imaging. And what we found? We found an ephysematous pyelonephritis plus an infected cyst plus a small colo-renal fistula. In this imaging, we can see this actual CT scan with air inside the left kidney and also air surrounding the left parenchyma. And this figure too, we can see the air inside the left kidney and a visible fistulosus tract connecting the left kidney and also the splenic flexure of the colon. So here's the fistula. It's important to mention that the fistula provokes the air go inside the kidney. When we make the surgery, we can see the fistulous tract connecting between the splenic flexure of the colon and the left kidney. Here in this blue arrow, we can see the fistula. So when we do the lumbotomy, we identify the abscessed cyst and also the fistula, and we call to the general surgeons to help us to make the primary closure of the colon, and we help as the closure of the kidney. The surgical finding was the 3/1 centimeters fistula between the splenic flexure and the left kidney. And it's important to mention that the postoperative evolution and the postoperative outcome of the patients was very interesting because the patient returns home without any complications. We can see the lumbotomy and also the Jackson-Pratt drain. The patient returns home in a good condition. Results and discussions. Well, colo-renal fistula, as I told you, are extremely rare conditions, especially rare outcome of an infected renal cyst. We suppose that the possible mechanism of this fistula could be the rupture of the cyst, or maybe the rupture of the diverticulum, and this diverticulum opening to the cyst. Key lessons, well, I suggest to resist renal cyst with there is no new symptoms when new symptoms appears, we have to repeat an imaging because it is crucial to an early diagnosis and also an early management. As I told you, we call to the general surgeons to help us in the colon closure. That's why I wrote here that multidisciplinary management improves the outcomes. And that's what can I say about this case report. Thank you for all, and thank you for this opportunity to talk about this rare case.
Thank you
I'm
so
open
much
for any
for
questions.
your excellent presentation, Dr. Posada. So now I'll be opening the floor to the judges for questions.
And so, Dr. Velez, I agree. Yes, it's a very interesting case, and yes, we've gotten a nice coverage of the surgical outcome of the patient in terms of, they had hypertension, they had diabetes, they had this flank complication of a fall, and you went in and did nice work in terms of the surgery, stitching up the patient very nicely. It would be nice to find out what the follow-up is with this patient, how are they, managing, or how are they improving, because I'm assuming there has to be some antibiotic coverage. Do you have any of that information in terms of this elderly patient who has comorbidities that adds to the complication?
Okay, first of all, we treated the patient about the clinical symptoms before the surgery with antibiotics, and we send the patient at home with antibiotic treatment as ambulatory treatment with antibiotics who cover gram-negatives and also Enterococcus bacteria. So she developed a very good outcome finishing the treatment. Now that the patient is alive, and also she is enjoying maybe in this Christmas the turkey dinner also.
Okay, thank you so much for that answer.
Thank you so much.
Okay, thank you, Dr. Gazel-Williams. So now I'll be moving on to questions from Dr. Mukita, who asks, is there any effect on the right kidney in this patient? And what is the final outcome of this case?
Well, what can I say is that the patient now is a monorenal patient, yeah? So it's important to know that the patient lost the function of the left kidney because many days after the surgery, we keep up the left kidney and she just have the right one. It's important that to mention in this case that the patient had just one kidney, and also all the function of the kidney had the right one.
Thank you so much. And for our next question by Dr. Fernando, she asks, in an elderly female patient who may have comorbidities, what were the critical factors in deciding between a single-stage procedure, resection with primary anastomosis, versus a multi-stage procedure like a Hartmann's procedure?
Well, principally here in Ecuador, the lack of resources. We cannot make many surgeries here because there is a lot of patients waiting for a surgery, and I understand that could be in 2 times the surgery, but the patient was really good as a clinical condition. That's why we decide to make it in just 1 time. Also, it's important to mention that the patient was treated previously with antibiotics. They was previously treated the clinical status previous the surgery. So that's why we decided to make in just 1 stage.
Thank you so much for the questions from the judges and also the answer as well. So now, judges, please feel free to take this transition time to submit your judging response form, and we will now be displaying a QR code for audience voting. So please scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. Before we continue on with our next presentation, I would like to introduce our new judges who will be joining us to also for our additional presentations. So first one is Professor or Dr. Asmita Nini, a professor of pathophysiology at the Medical University of the Americas in the West Indies. Welcome, Dr. Nini. And second is Dr. Neil N. Patel, from the Department of Cardiovascular Medicine at the University of Tennessee Health Science Center at Nashville, Tennessee, United States. Welcome, Dr. Patel. And finally, Dr. Bella O'Day, who is from the Public Health Methodology Department in the University of Brussels. Welcome, Dr. O'Day. Thank you so much. So now we will be continuing on with our next presentation from Dr. Sri Thabasni SK from India, who will be presenting their original research on cognitive impairment and its influencing factors among elderly at residential homes in Western Tamil Nadu, a cross-sectional study.
So hello all, I'm Sri Thabasni, a final year medical student from Karpagam Faculty of Medical Sciences and Research, Coimbatore. So my study was a cross-sectional study on cognitive impairment and its influencing factors among elderly staying at residential homes in Western Tamil Nadu. So why particularly choose this elderly age group? It is because by 2050, it is estimated that the global elderly population will be double the current size. And nearly 20% of Indians of that time are going to be elders. They are prone to a lot of comorbidities, of which cognitive impairment is a major factor, which is a decline in their memory, attention, or executive function. Though not typically dementia, this acts as a precursor to it. So assessing that will definitely help in reducing the caregiver burden and improve the quality of life. So there are various factors, societal factors like increase in urbanization, rise in nuclear family, where the number of elders being in the institutional care setups have raised. They face isolation and reduced social stimulation, further increasing their vulnerability. So this cognitive impairment is a very major and growing public health concern, especially of those institutionalized elders, which remains a relatively unexplored setting. So addressing this remains very much crucial. The main aim of the study was to assess the prevalence of the cognitive impairment and its influencing factors among elderly residing in old age homes in Coimbatore. With the methodology, it was a cross-sectional study at old age homes conducted during a period of 3 months, and elderly above the age of 60 and residing in the homes for more than 6 months were included, and those who couldn't comprehend critically ill and had other visual impairment were excluded. Sample size of 200 was calculated based on the previous study who had a prevalence of 41.6% of cognitive impairment. Now here this flowchart depicts the entire flow of the study. The sampling technique was multi-stage random sampling, and nearly 61 old age homes, the total number of old age homes were obtained through proper permission. 13 of them gave permission to involve in the study, and the first stage of simple random sampling was done at this stage, and 4 homes were selected, and the eligible list was created with the exclusion and the inclusion criteria. In another stage of simple random sampling was again applied. From the eligible list, 200 participants were included. And the study tool, it was a pre-tested semi-structured questionnaire. It collected socio-demographic data, and to assess cognition, the Montreal Cognitive Assessment Scale was used. Now this is the scale. It actually assesses 8 cognitive domains, namely visuospatial or executive, naming, memory with immediate recall and delayed recall, attention, language, abstraction, and orientation. Of the total score of 30, above 26 is considered to be normal, between 18 and 25 mild, 10 and 17 moderate, and below 10 is considered to be severe. And the data was entered in MS Excel and analyzed through statistical package for social sciences. Now here we have the author certification to apply and interpret the MOOC. With the results, here we have this box and whisker depicting the age distribution. We have the range between 60 and 85 in this population, and we have the median of 68. And here we have this gender distribution with 43% females and 57% males. Here we have this radar plot depicting the cognitive impairment status. We have orange with females and blue being depicted by depicting males. In the mild category, we have nearly 16.5% of females and 14% males. Among moderate and severe, we have observed a higher prevalence in men than women. So we see that nearly 30% males and 19% females with moderate impairment, and 13% males and 5% females with severe impairment. And interestingly, there were no men with normal cognition, and 2.5% of the females had normal cognition. And with the predictors, we had statistical significance for gender, education, and pension status. And we found the male gender, illiteracy, and non-receiving pension status have a higher odds to develop cognitive impairment. There were no statistical significance for past occupation or financial status. Now, with the discussion, with the 200 elderly in this population, all the men had cognitive impairment and only 2.5 females were normal. This was in contrast to the previous study, which had a female predominance. Also, the study observed comorbidities like hypertension, diabetes, and sleep disturbances, and impairment of cognition was associated with pension status, gender, and literacy, both of which was inconsistent with the previous studies. So the limitations, that could be confounding bias because pre-existing depression and malnutrition were not evaluated, and government-run homes were not included in this study. With the conclusion, the overall burden was very high and alarming, with 97.5% and nearly 67%, nearly two-thirds of the total contributed by moderate and severe. Study also highlights the fact that cognitive impairment could be caused by multiple factors. Thus, it is very much essential we detect these cognitive impairments early in order to preserve the quality of life of those elders. Having said that, with the practical implications, which is very much necessary that we integrate the routine cognitive screening at the primary healthcare level and residential homes, which of course requires proper training of the healthcare workers. And especially in India, we have this national program for the healthcare of the elderly, which actually provides a very affordable geriatric care, but it mostly remains underutilized. So awareness in community level is very much required to increase this utilization. And in individual level, the individuals can be engaged in fine motor skills, or they can involve in group interactions to improve their social stimulation and slow down their cognitive aging. Strengthening referral pathways and prioritizing our preventive care is very much essential so that we ease the burden in the system and promote healthy aging. So to conclude, I personally believe the care that we give for elders today is the investment in the dignity we all hope for in the future. So with the references, and thank you. Thank you for your patient listening.
Thank you so much, Ms. Nasi, for your excellent presentation. So now we're going to open up the floor to questions from our judges. And the floor is yours, whoever would like to start first.
Just a moment.
To our judges, yeah, no worries.
Yeah, I would like to ask one question.
Please.
Was there any criteria to decide BMI or age and exercise tolerance in these individuals? Was there any category?
Yes, thank you for the question. Actually, we assessed BMI, but for the exercise tolerance and things, we didn't actually adjust for that. But BMI was evaluated.
So was there any significant difference?
No, there was no significant association or difference between those with normal BMI or with other categories.
Thank you, Dr. Nini. And Dr. Ode or Dr. Patel, any questions that you would like to ask?
No question at the moment.
Sounds good. Dr. Patel?
Is he no longer with us? I think that he's having current issues, technical issues, so he has re-entered the studio. So
Technical difficulties.
Hi, Dr. Patel. Do you have any questions for our presenter? Okay, no worries. It seems like we're experiencing technical difficulties. Thank you so much, Babnasi, for the excellent presentation. So now, judges, please feel free to take this transition time to submit your judging response form. We will now be displaying a QR code for audience voting. Okay. And please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during tomorrow's ceremony. So please don't forget to participate. Thank you. All right, now we'll be moving on to our next presenter, Miss Catherine James from the UK, presenting her original research on mobile phone use and hand grip and pinch strength in the SCAMP study. So she is currently not with us, so we will be presenting her video instead.
Catherine James, and I'm a medical student from Imperial College London. It's an honour to be. Good afternoon, my name is Catherine James and I'm a medical student from Imperial College London. It's an honour to be here today to share my research with you. It looks at mobile phone use and its association with hand grip and pinch strength in adolescents through an examination of the SCAMP study. Hand strength has been shown to have a strong relationship with general well-being, reflecting musculoskeletal function and levels of physical activity. Higher grip strength in adolescence is associated with a lower premature mortality risk in young adulthood, independent of BMI and blood pressure. Hand grip strength has been shown to be a reliable measure of muscle strength in all phases of the life course. This slide shows the direct and indirect mechanisms by which mobile phone use might lead to weaker hand grip and pinch strength. The relationship between phone use and grip and pinch strength in adolescence is poorly understood. The majority of studies have small sample sizes between 40 and 280, a high risk of confounding bias, and limited causal inference. They are predominantly undertaken in university student populations, with only 2 of the studies including younger children. We had 2 aims for this study. Firstly, to understand whether mobile phone use is associated with hand grip and or pinch strength in adolescence. And secondly, if any of these observed associations differ between the dominant and the non-dominant hand. In 2014 to 2016, the SCAMP study involved 7,000 pupils from 39 secondary schools, 26 state and 13 independent across Greater London. Since then, SCAMP has expanded further to approximately 11,000 with more recent recruitment, but this work focuses on those recruited in the initial phase. This slide shows the exposures and outcomes that were used. Hand grip strength was measured for both hands using a handheld JMA dynamometer. Participants were instructed to squeeze the dynamometer as hard as they could. Tip pinch, thumb tip to middle index fingertip. Key pinch, thumb pad to the lateral aspect of the middle phalanx of the index finger. And palmar pinch, thumb pad to the index and middle fingers, strength were measured in kilograms for both hands using a JMA pinch gauge. Participants were instructed to pinch the gauge as hard as they could for each measure. Each grip and pinch measure was taken once, for each hand, at every time point. Multi-level linear regression was undertaken, controlling for the covariates shown. Preliminary results show no association and no significant trends across exposure categories. This slide examines the change in exposure between baseline and follow-up by activity. This suggests that text messaging and mobile phone social network use is associated with a stronger hand grip and pinch strength at follow-up. In conclusion, this is the first longitudinal study to examine relationship between smartphone use and grip and pinch strength. It is also the first study based in the UK on this topic. We've proven that messaging on a phone is associated with stronger hand grip and pinch strength in adolescents. Thank you so much to everybody who has made this project possible. And thank you for having me here today to tell you about some of the amazing research I've had the chance to take part in. I hope you have a lovely rest of the conference.
Thank you so much for that excellent presentation, Ms. James. It's a shame that we could not see you virtually, but now we're going to take this time. Judges, please go ahead and submit your response form. And as for the audience, we will be displaying a QR code for audience voting. Again, please scan the QR code on the screen that will be showing shortly to vote for your favorite presentation.
Okay, sorry.
Your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. Thank you so much. So now we will be moving on to our final presenter in the second session, Mr. Tyler Perlberg from the United States, who will be presenting his original research on the effectiveness of haptic feedback devices in reducing pain perception during intra-articular corticosteroid injections in rural Guatemala and Kenya, a randomized controlled trial. Mr. Perlberg, whenever you are ready, please share your screen and proceed.
Great. All righty. All right. Hi, everyone. My name is Tyler Perlberg. I'm a fourth-year medical student from Kansas City University College of Osteopathic Medicine. And today I'll be presenting our study titled Effectiveness of Haptic Feedback Devices in Reducing Pain Perception During Intra-Articular Corticosteroid Injections in Rural Guatemala and Kenya, a randomized controlled trial. I would like to thank my co-investigators, Al Felipe, Carmen Tong, Jordan Constanti, and Dr. Guadam Desai. Osteoarthritis, or OA, is the most common joint disease worldwide. It's characterized by degeneration of articular cartilage, urination, osteophyte formation, and inflammation. Globally, OA affects an estimated 595 to 607 million people, with prevalence rates exceeding 7% of the world's population. Intra-articular corticosteroid injections are widely used treatment for moderate to severe OA. They're especially beneficial in low-resource areas, such as rural Kenya and Guatemala, where this study was conducted, because the long-term oral medications, consistent follow-up, and physical therapy may be inaccessible. These injections can provide longer-term relief with minimal intervention between treatments. However, in these same low-resource settings, image guidance or anesthetics like lidocaine are often unavailable, which can make the procedure painful and anxiety-provoking for patients. Haptic feedback, such as tactile stimulation through vibration devices or textural objects, has been shown to modulate pain perception in clinical settings. It represents a simple, low-cost and non-pharmacologic option to reduce procedural discomfort in environments where pain control resources are limited. Although resource on this topic is limited, a study by Yim and colleagues in 2022 demonstrated that the use of a handheld soft robotic device during a pain research protocol led to decreased pain perception in 66 participants. This finding formed the background basis for our study. Given this background, we wanted to explore a simple, low-cost way to make injections more comfortable in resource-limited settings. Our aim was to evaluate whether handheld vibration devices could reduce pain perception during steroid injections in patients with OA seen through our medical school's global health outreach programs in rural Kenya, shown in the picture to the right, and Guatemala. We hypothesized that haptic feedback devices during the injections would decrease perceived pain compared to standard care. The study was designed as a randomized controlled trial through KCU's global health outreach clinics. We enrolled 37 adult patients with OA who were scheduled for steroid injections. 4 patients were excluded due to protocol deviations or incomplete data, leaving 33 in the final analysis, with an average age of about 66 years, similar between both groups. Most had knee OA, which accounted for 89% of the sample, while smaller numbers received injections to the hand or shoulder. Participants were randomly assigned in a 1-to-1 ratio to either a control group, which received standard care, or a haptic group. In the haptic group, patients held a handheld small vibration device in the opposite hand during injection, as you can see here in this photo. This image shows one of our participants receiving a left knee injection while holding a vibrating ball in his right hand, providing the tactile stimulation throughout the procedure. Pain perception was measured immediately before and after the procedure using the Wand-Baker Faces Pain Rating Scale, shown at the bottom right of the screen, which ranges from 0 to 10 and is especially useful in cross-cultural and multilingual settings like the ones in this study. Statistical analysis was performed using the Mann-Whitney test to compare differences between groups and the Wilcoxon sign rank test to analyze changes within groups. Overall, this study allowed us to evaluate whether introducing a simple low-cost haptic feedback device could meaningfully reduce pain perception during corticosteroid injections in low-resource global health environments. As noted at the bottom of the screen, we found a significant reduction in pain across all participants, an average decrease of just over 4 points on the Wong-Baker Faces scale, with a p-value of less than 0.001. There was no statistically significant difference between the two groups, and the majority of patients in both groups reported less pain than expected before the injection, while only 2 reported increased pain and 7 reported no change. Looking at the table, the haptic group included 17 participants, while the control group had 16. In the haptic group, the average post-injection pain was 2.35, with a significant decrease of 2.73 points from baseline. In the control group, the average post-injection pain was 1.44, with a significant decrease of 3.22 points. When comparing the two groups, the between-group p-value was 0.058, showing no statistically significant difference in average decrease in pain. Still, 76% of participants in the haptic group and 62% in the control group experienced less pain than they had expected. Overall, both groups showed meaningful pain reductions, confirming that intra-articular corticosteroid injections can be well tolerated even in low resource settings. These findings led us to several key conclusions. Our handheld vibration device did not significantly reduce pain compared to standard of care during intra-articular corticosteroid injections. However, a higher percentage of patients in the haptic group reported experiencing less pain than expected. Interestingly, both groups reported significantly lower pain overall. This may reflect psychological or contextual factors, such as procedural familiarity, since participants in the study required a more thorough explanation of the injection process and what to expect. That additional communication and reassurance may have played a larger role in reducing perceived pain than the vibration device itself. Limitations included communication barriers despite translator support, procedural variability among injectors, and an imbalance in the joint types treated. In summary, haptic feedback may be a feasible, low-cost, non-pharmacologic adjunct for pain control in resource-limited settings. Further studies with larger sample sizes and standardized techniques are warranted to define its role in pain modulation. Thank you.
Thank you so much for that excellent presentation, Mr. Perlberg. So now I'll be opening the floor for questions from our judges.
If you still have plenty of time.
Hi, whenever you're ready, Dr. Ode or Dr. Nini, you can go ahead and ask your questions.
I have to go out there.
So I have one question. What is the possible mechanism to reduce pain with such devices, vibration-inducing devices, according to the literature?
Yeah, according to the literature, it's just kind of like a distraction device so that they're not as focused on what's going on during the injection or focusing on the pain. So just like another stimulation. It doesn't necessarily have to be a vibration device. It could even just be like a textural surface or something to just distract them from what's going on.
Hi, Doctor. Thank you so much, Dr. Nini. Dr. Ode, did you please feel free to ask your questions.
Thank you for your presentation, and I wish to find out that if the probability of changing the joints, could it be that probably it could be the knee joint, and we had these results. If probably it was another joint also, are we expecting to have similar results, or there is probably I don't know if you understand my question.
Yeah, I think you're saying, would there be different results if there was a wider variety of joints being injected?
Yes.
Yeah, that's a great question. And honestly, I think that warrants more follow-up studies. I would imagine that it would be pretty similar, but again, we're holding the device in the opposite hand. So that could maybe affect it if it was in if there were more injections in the shoulder or the hand. But I think that would be a really interesting follow-up to get some more participants and patients with different joint pathologies.
Okay, thank you.
Yeah, thank you.
Thank you so much, Dr. Ode and Dr. Nini. So go ahead and take this transition time to please submit your judging response form. And thank you for your presentation, Mr. Perlberg. And now we will be displaying a QR code for audience voting. Please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. Thank you all very much. Welcome back to our third and final session of the day. We hope that you enjoyed your lunch break. We will now be proceeding with our third session of oral presentations for the day. I do want to welcome one more additional judge, Dr. Adeniyi Mayoya Jeremiah, Senior Lecturer of the Department of Medical Physiology, College of Medicine at the University of Rwanda. Welcome, Dr. Jeremiah. We are so pleased that you are here. So next, we're going to...
Thank you very much. It's my joy to be here this very period. It's my joy to join people. It's my privilege. It's a very good privilege for me to join this hallowed conference. Thank you very much.
Thank you, Dr. Jeremiah. Appreciate it. So now we'll be moving on to our first presentation. So Miss Rebecca Ioana Rus from Romania. So she is presenting a case report on avoiding pacemaker, resolution of sinus node dysfunction through CPAP therapy.
Hello everyone, my name is Rebecca Ioana Rus from Iuliu Hatziaganu University of Medicine and Pharmacy from Romania, and today I am presenting a compelling case study titled Avoiding Pacemaker, Resolution of Sinus Node Dysfunction Through CPAP Therapy. Sleep apnea, hypopnea syndrome is a highly prevalent yet often underdiagnosed disorder with profound cardiovascular consequences such as hypertension, heart failure, and increasingly arrhythmias and conduction abnormalities. Our focus today is on sinus node dysfunction, which is among the most frequently reported rhythm disturbances in sleep apnea-hypopnea syndrome patients. Clinically, this manifests as bradycardia or prolonged sinus pauses. The underlying pathophysiology is linked to recurrent nocturnal hypoxemia, which drives a significant sympathetic vagal imbalance, leading to electrical instability in the sinus nodes. Traditionally, pacemaker implantation has been the standard of care for symptomatic or severe sinus node dysfunction. However, a crucial question must be asked is the sinus node dysfunction truly irreversible? Because growing evidence suggests that treating the underlying cause, in our case, sleep apnea-hypopnea syndrome, with CPAP can resolve these rhythm disorders. This highlights the critical need to identify and treat reversible causes before resorting to the invasive ones, such as permanent device implantation. This case report aims to highlight exactly this point, the potential for CPAP to completely reverse the sinus node dysfunction. So, we report the case of a relatively young 34-year-old male presenting with significant morbid obesity. His primary complaint was severe daytime sleepiness with an Epworth score 17. Also, he had no cardiovascular history and no evidence of structural heart disease on examination. The initial evaluation showed sinus bradycardia at 56 BPM on the baseline ECG. Holter monitoring confirmed the severity of the problem, revealing sinus node dysfunction with profound nocturnal pauses up to 6.8 seconds. So, based on these findings, pacemaker implantation was initially considered. However, a simultaneous overnight polysomnography was performed, which confirmed severe sleep apnea-hypopnea syndrome with an apnea-hypopnea index of 70 events per hour and also a oxygen saturation of 56%, a dangerous one. Crucially, there was a direct temporal overlap between the severe apneic events and the cardiac causes. This correlation led us to pursue an alternative, non-invasive strategy before proceeding with device implantation. Okay, so this slide actually shows the most critical diagnostic finding. This is the actual Holter trace showing the 6.8 second sinus pause. Also, this profound pause immediately followed a 52 second apnea, during which the patient's oxygen saturation plumbed to 56%. This is the strongest evidence linking the sleep apnea-hypopnea syndrome to the sinus node dysfunction. The patient was immediately started on CPAP therapy and also received counseling for weight loss. At the 1 month follow-up, the clinical response was dramatic, complete resolution of daytime sleepiness. The repeat polysomnography also showed a significant improvement with the apnea-hypopnea index almost halved, reducing from 70 to 38 events per hour, and also the oxygen saturation improving from 56% to 70%. Most importantly, repeat Holter monitoring confirmed the complete normalization of sinus rhythm. The mean heart rate increased from 56 to 68 BPM, and critically, no further sinus pauses were detected. So the planned pacemaker implantation was avoided. In conclusion, this case highlights the complete reversibility of severe sinus node dysfunction through the treatment of sleep apnea hypopnea syndrome with CPAP therapy, with the CPAP therapy. This underscores a crucial clinical message. We must systematically consider sleep disordered breathing in patients presenting with unexplained bradyarrhythmias, especially in younger individuals without the traditional cardiac comorbidities. Identifying sleep apnea hypopnea syndrome as the underlying cause can dramatically alter the therapeutic strategy, preventing an unnecessary invasive procedure and its associating long-term complications. CPAP should be recognized not just as a quality of life treatment, but as a potential disease-modifying therapy for rhythm disturbances like secondary to sleep apnea. So early screening and prompt initiation of CPAP should be a decisive step in redefining the management of sinus node dysfunction in this context. Thank you very much for your attention.
All right, thank you so much to Miss Rebecca Joanna Roos. So we were sad to unfortunately miss you. But as for next steps, since she is not here, we don't really need to open the floor for questions for judges yet. So judges, if you can, please take this time to submit your responses to the judging response form. And now we will be displaying a QR code for audience voting as well. So please go ahead and scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. So we will be moving on to our next presenter, Dr. Karma Dicky Sherpa from Bangladesh. So she is presenting a case report on a case of Rosai-Dorfman disease.
Hello everyone, I'm Karma Dicky Sherpa from Nepal, currently an intern doctor at TMS's Medical College and Rafatullah Community Hospital in Bangladesh. Today I'll be presenting a case report on Rosai-Dorfman disease, highlighting its clinical significance and relevance. I hope you'll find this presentation very much informative and engaging. So let's begin our presentation. Rosai-Dorfman disease, a case report. Background. Rosai-Dorfman disease is a rare form of histiocytosis. It is a non-Langerhans cell histiocytosis that commonly presents with significant lymphadenopathy and may or may not have systemic symptoms. Frequently affected organs include nasal cavity and sinuses, gastrointestinal, pulmonary, renal, musculoskeletal, and genitourinary systems. Dermatological symptoms manifest in only about 10% of the cases and presents with papules, nodules, plaques, or lesions when it does. The case. A 25-year-old lady had a 1-year history of discomfort and swelling in the helix and antihelix of the ears and dyspnea of MRC grading 2. A clinical diagnosis of relapsing polychondritis was made by an ENT surgeon. Then she was prescribed with oral steroids and SAIDs and also salbutamol inhaler as a treatment. But the symptoms progressively worsened, and she presented to medicine outpatient department the next time. By the time of presentation, her left ear had become more swollen, dyspnea had worsened to grade 3 of MRC scale, and she had also developed a cervical lymphadenopathy this time. On examination of the patient, local examination revealed bilateral enlargement of the ear helices and antihelices, resembling cauliflower-like appearances, as shown in figure number 1 and figure number 2. Figure number 1 showing right ear and figure number 2 showing the left ear. On general examination, patient was well-built, afebrile, and not in acute distress. No pallor, jaundice, or pedal edema were found, but there were multiple bilateral painless cervical lymphadenopathy. On systemic examination, no hepatosplenomegaly was found. Cardiovascular, respiratory, and neurological systems were within normal. On investigation of this patient, routine laboratory investigations besides chest X-ray were normal. Chest X-ray is shown in figure number 3 that I will discuss in the later slide. Spirometry revealed an obstructive pattern with forced expiratory volume in 1 second of 3.2 liter. An HRCT scan of the chest with contrast was also done. Here in the figure number 3, chest X-ray PA view of the patient is shown, which is suggestive of bilateral hilar and infrahilar lymphadenopathy. In figure number 4, HRCT scan of the chest shows diffuse mediastinal lymphadenopathy. Here, FNSC from the left ear and biopsy of cervical lymph node were also done, as a result of which proliferation of the histiocytes with abundant cytoplasm and prominent nuclei in most of them were seen. These cells were found admixed with plasma cells, Russell bodies, lymphocytes, and neutrophils, showing features of emperipolysis, as shown in figure number 5. Apart from these investigations, some other investigations were also performed to exclude the differential diagnosis like systemic lupus erythematosus, autoimmune lymphoproliferative syndromes, lymphoma, tuberculosis, sarcoidosis, etc., where serologies for antinuclear antibody was positive and anti-double-strand DNA was negative. Investigations concerning sarcoidosis and tuberculosis were found negative. As a treatment, we provided oral methotrexate to the patient and also salbutamol inhaler to comfort the dyspnea, and a watchful waiting strategy was applied. Discussion part. Here I presented a case of Rosai-Dorfman disease, characterized by both nodal and extranodal involvement, initially presenting with bilateral ear nodules and dyspnea that closely resembled the clinical features of relapsing polychondritis, and misdiagnosed unfortunately. Due to its diverse manifestation, it might take years to reach the diagnosis following the clinical signs. Hence, this disease is evaluated with proper history taking, physical examination, laboratory studies, imaging, and biopsy. There is no standardized treatment method established for Rosai-Dorfman disease so far, and the treatment options can be customized based on the severity and extent of the disease. But it is often wise to adopt a watchful waiting strategy, as spontaneous remissions can occur in about 20 to 50% of individuals with nodal and cutaneous disease and without any systemic complication. At last, I would like to conclude my presentation by highlighting these 3 important points. Rosai-Dorfman disease is a rare, often misdiagnosed histiocytic disorder that can mimic conditions like relapsing polychondritis, lymphoma, and many more. Early and accurate diagnosis is crucial to prevent unnecessary and inappropriate treatment and to improve the patient outcome. Hence, this case highlights the clinical necessity for greater awareness and education among healthcare professionals regarding Rosai-Dorfman disease. I would like to acknowledge the patient for giving me the permission to present this case, to the principal of the TMSS Medical College, and of course, the man behind the diagnosis of this case, Dr. Ahmed A. Montasir. I would also like to express my heartfelt gratitude to the Radiology and Imaging Department of TMSS Medical College and the Pathology Department of Bangladesh Medical University. Ethical issues. There were no any conflict of interest. A part of cost of investigations was sponsored by TMS's Health Sector Administrative Authority, and a proper written informed consent was obtained from the patient. These are my references, and I would like to express heartfelt gratitude to all the listeners for their valuable time, and I would be happy to receive any questions from the judges. Thank you so much.
Thank you so much for your presentation, Dr. Sherpa. We are so glad that you were able to join us in person for the question and answer session. So now I will be opening the floor to the judges to ask any questions.
Okay, thank you for your brilliant presentation. Please, I wish to ask, was it only the symptom of the swelling in the ears that you came with a different diagnosis of polychondritis, or there were other associated symptoms?
Ma'am, thank you for
for
your
the initial
question.
diagnosis of polychondritis.
Yes, initially the patient presented with the ear, like the discomfort and swelling in the ear that resembled like a cauliflower appearance, and another feature was dyspnea. She also presented with dyspnea. These two features were the initial feature that she presented with.
Okay.
Yeah.
Thank you, ma'am.
Yeah, thank you for your case presentation. Was there any CD markers done in this case to diagnose the condition and differentiate it from polychondritis? Is there any role of CD markers?
Thank you, ma'am, for your question. Like in this patient, to be honest, we performed only that biopsy and FNAC, like histopathology one, and the immunochemistry, like those like CD 68 and S100, like those were like yet to be performed. Like so far till now, like we performed that FNAC and biopsy, and those were confirmatory enough to diagnose the Rosai-Dorfman disease. That's why we performed these two.
Okay, thank you so much, Dr. Nini and Dr. Ode, for your questions. And thank you so much, Dr. Sherpa, for being able to join us. So now, judges, please go ahead and take this transition time to submit your judging response form. And now we will be displaying a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during tomorrow's ceremony. So again, please don't forget to participate. Thank you. Now we'll be moving on to our next presenter, Ms. Sofia Bermudez Rodriguez from Colombia, who will be presenting her original research on entitled Effectiveness of Trimethoprim-Sulfamethoxazole in cyclosporiasis, a meta-analysis of randomized controlled clinical trials. Hi, Ms. Rodriguez. May you go ahead and unmute yourself?
You can see the slides?
Not quite. May you go ahead and share? Yep. Yep, we
Okay.
can see it. Yes, please proceed. Thank you.
Okay, good afternoon, everyone. My name is Sofia Bermudez Rodriguez, and I am a fourth-year medical student at the University of Quindío in Armenia, Colombia. Today, I am ready to present our study titled Effectiveness of Trimethoprim-Sulfamethoxazole in Cyclosporiasis, a meta-analysis of randomized clinical trials. This study was carried out together with my college and under the supervision of Dr. Jorge Enrique Gomez Marin, head of the molecular parasitology group, HEPAMOL. Let me begin by give you some background of this disease. Cyclosporiasis is an intestinal infection caused by Cyclospora cayetanis, a parasite transmitted through contaminated food and water. It spreads through, especially in tropical areas. In children under 5 years of age, it causes around 10% of diarrheal cases. Typical symptoms include water diarrhea, fever, and fatigue, and this disease represents a public health challenge because of foodborne breaks and healthcare costs. The main treatment is trimethoprim-sulfamethoxazole, but until now, its true effectiveness had not been confirmed by a meta-analysis, and that gap motivated our search. Our main objective was to evaluate the effectiveness of trimethoprim compared to placebo for patients with cyclosporiasis. We focus on two case outcomes, parasite eradication and clinical recovery. To answer this question, we performed a meta-analysis included only randomized controlled trials or also called RCTs. Now, we explain how we carried out the studies. We searched PubMed, Scopus, and Google Scholar for studies published up to May 2025. Only randomized trials with a confirmed diagnosis of Cyclospora cayetanis were included. Each trial had a 7-day follow-up after the treatment, and we assess quality using the Cochrane risk of bias to toll. Then we calculate the risk difference, or RD, with 95% confidence intervals applying a random effect models. With this method, we ensure the results were compared and reliable. Next, I will show you what we found mod. This figure shows the forest plot summarizing the 3 trials included, Hodge, Medico, and Shim, and each horizontal lines represent a study. And the blue square shows the effects of trimethoprim versus placebo. All the squares are placed on the left side of the vertical line, meaning trimethoprim-sulfamethoxazole was more effective. And at the bottom, the black diamond represents the combined effect for all studies. The pooled risk difference was minus 0.84, which means trimethoprim-sulfamethoxazole reduced the risk of persistent infection by about 84%. And the heterogeneity with an I-squared value of 30% was moderate, showing that the results were fairly consistent. Now, let's discuss what the results mean. First, our analysis showed that trimethoprim-sulfamethoxazole consistently performs better than placebo for both parasite eradication and clinical improvement, although some variation exists among studies, and the overall trend was the same. One trial had low risks of bias, one moderate, and another high, so the results should be interpreted with caution. Clinical, this finding support trimethoprim-sulfamethoxazole as the current standard therapy of cyclosporiasis. We recommend in future studies with large samples and longer follow-ups and a diverse pollution. And with this in mind, let's move to our main conclusions. In conclusion, our meta-analysis suggests that trimethoprim-sulfamethoxazole shows a strong evidence of benefit for patients with cyclosporiasis. It's appeared to improve both clinical recovery and parasite eradication when compared to placebo. However, because the number of studies is small and their quality varies, the results should be interpreted with caution. We need more large and well-designed clinical trials are needed to confirm these findings and to strengthen future treatment recommendation. This is the main reference that we used. And we would like to thank the University of Quindío and the Molecular Parasitology Group HEPAMOL for their support and guidance through this project. And I also want to extend a special thank you to the conference organizer for providing this space to share our work for promoting students' participation in global scientific discussion. Thank you very much for your attention.
Thank you so much, Ms. Rodriguez, for your excellent presentation. So now I will be welcoming the judges and opening the floor for questions from our judges.
Hi, good afternoon. Thank you for your presentation. You compared the drug-treated patients with placebo patients. So how was the recovery in placebo-treated patients? Did they recover without medicine, or what was the alternative therapy given to them?
Ms. Rodriguez, I think you're muted. Yeah, go ahead.
Thank you for the question. In the placebo group, patients didn't receive the investigational drug, but they didn't receive the standard of care treatment recommended in clinical guidelines for their condition. They include all usual supportive and symptomatic measures. This is the question, or no? Yes. Yes.
So they recovered without any antibiotic. Is the
No, especially they cover the progressive clinical improvement at slower pace with less overall response compared with those who receive the active drug. They receive the standard, basically.
Yeah. So what was the difference in the duration of recovery? The patients who were treated with drug and the patients who were treated with placebo, was there any difference in the duration of the recovery of the patients?
You can repeat the question, please.
How much time did the patients take to recover from the infection when they were treated with the drug and when they were treated with placebo? Was there any difference in the duration of recovery period? How long did they take?
Around 10, 20, 10 days. It's the reference that we found in the different article.
Okay, thank you.
Okay, thank you for your presentation.
Hello. Okay.
Oh, sorry. Hi, Dr. Adini. I'm going to ask Dr. Ode to go first, and then you'll go after, okay? So yeah, go ahead, Dr. Ode.
Okay, thank you for your presentation. I wish to ask, did you have maybe some justifications of why you took studies that had treated a patient with trimethoprim and sulfamethoxazole for 7 days post-treatment? Did you have like some justifications? Why did you take just up to 7 days, or maybe you could exceed? Or did you have some justifications for that?
I don't understand the question. Sorry. You can't read in the chat. Tested.
Okay, I was asking, like, when you were selecting the studies. I was asking the studies which you selected that had treatment of the infection, the parasitic infection, for up to 7 days. Do you have like a justification why you choose treatment for up to 7 days? The studies that had treatment for up to 7 days, or it was just, do you have any justification for that? Or I don't know if you get me clearly. For your criteria of selecting the studies, I saw up to 7 days post-treatment. Was there a justification for that?
Ms. Rodriguez, were you able to understand the question or hear the question?
No, you can't check in the chat the question because I don't know.
Okay, she asked if there was any justification, like any reason that you could give regarding why the treatment was only 7 days after. Is that kind of what you were asking, Dr. O'Day? Why you chose
why did you select studies? Yeah, up to 7, like post.
Why did you select
7 days
studies that only treated until like 7 days? Why did you
7
select
days.
studies?
Okay, we select the studies that in 7 days recover. They have a test to evaluate in the time, because in the bibliography we found that the recovery with Trimethoprim-Sulfamethoxazole was in 7 days. Of these 4, other studies evaluate this time based on the bibliography.
Thank you so much for your presentation. And judges, go ahead and please take this transition time to submit your judging response form. We will now be displaying a QR code for audience voting. Please scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. So our next presenter is Miss Nisreen Ahmed from the UK, who will be presenting her case report entitled "One Step Forward, Two Steps Back, Functional Decline Following Lisfranc Fracture Dislocation." Unfortunately, Miss Nisreen Ahmed was unable to make the conference today, so we'll be presenting her video instead.
Hello everyone, my name is Nisreen Ahmed. I'm a 4th year medical student based in Anglia Ruskin University in London, UK, and I have produced a case report on a young patient, a 24-year-old male who encountered a Lisfranc injury, and it is titled "One Step Forward, Two Steps Back, Functional Decline Following Lisfranc Fracture Dislocation." So this case is about a 24-year-old male who sustained a Lisfranc fracture dislocation during a Brazilian Jiu-Jitsu training when his left foot was held in plantar flexion and abruptly subjected to axial load. The initial weight-bearing anterior, posterior and oblique foot radiographs revealed the hallmark feature of the Lisfranc injury, which is what we call the flex sign. If I could draw your attention to the cursor in the left-hand image radiograph, if you can see that there is a widening between the first and second metatarsal. This is what we refer to a flex sign, and it is an indicator of disruption to the Lisfranc ligament. And there is also lateral displacement of the second metatarsal base relative to the middle cuneiform, as well as subluxation across multiple tarsal-metatarsal joints, unfortunately. And that is very, very much clear because, as you can see, all the tarsal-metatarsal, all the metatarsals from the radiographs that you can see have all been shifted laterally. His fifth metatarsal is almost hanging on by a thread on the right-hand side, if you can see. And this is what we can maybe potentially call a moderate to severe case as well. And interestingly, this was all from a very small and very low energy injury. This is something we would normally expect to see in a high energy injury, but just shows that it is very possible in a low energy injury as well. So yes. So what do we do next? Discussions around whether to fix the joint through open reduction internal fusion, which can also be abbreviated into ORIF, or to fuse it via primary arthrodesis remains a subject of ongoing debate. ORIF aims to essentially restore the joint alignment whilst preserving motion, making it the preferred option for younger active patients. However, it is associated with higher rates of post-traumatic arthritis and hardware-related complications. As you can see from this image on the left-hand side, which is demonstrating an ORIF procedure, there's so much going on and there's so many cannulated screws and dorsal plates being inserted, you can only imagine some of the complications associated to this procedure post-operatively. In contrast, the primary arthrodesis eliminates the joint motion, but it offers a more predictable long-term outcome with lower revision surgery rates and symptomatic arthritis. However, which one is a more superior procedure? It's still an ongoing debate. Another issue I wanted to draw your attention to are the challenges in finding an orthopedic surgeon with specific training in Lisfranc repair. The inability to locate a foot specialist who are knowledgeable enough about cutting-edge joint-preserving therapy alternative has caused many patients, like in this case report, to experience delays in receiving adequate treatment. In this instance, this patient's surgery was delayed by 7 days while attempting to find a foot specialist with a Lisfranc repair experience or knowledge, which could have potentially impacted his recuperation. During this agonizing wait, the patient was immobilized in a hospital bed, exacerbating the physical and emotional distress. And this delay and the lack of greater specialist availability highlights the need for further research and access to specialists in order to enhance functional outcomes and lessen the long-term disability linked to these complicated injuries. So as mentioned, this patient is young and active, so the selected procedure for him that was decided in the end was the ORIF procedure, which involved placement of multiple cannulated cortical screws. So as mentioned, this patient is a young, active, athletic male who was assumed to have sustained this injury due to his foot being placed in a plantar flexion and being subjected to an abrupt application of axial load combined with rotation, and this precipitated an immediate pain and swelling. And as I've mentioned before, the surgical procedure that was highly debated but ended up being settled with was the open reduction internal fixation. And that involved placement of multiple cannulated cortical screws spanning the medial and middle columns, so that's the first to third metatarsal, along with dorsal bridge plates to restore and maintain the tarsometatarsal joint congruity. So, and a little fun fact for you all as well, if you are not aware, the Lisfranc term actually is derived from the surgeon that actually identified as a Lisfranc injury within the midfoot of a long time ago. And at the time, it was only managed with amputation. So we've come so far in orthopedic repairs. However, there still remains to be challenges and limitations, unfortunately. Now, unfortunately, in this case, this patient did have to have a second procedure, which involved the removal of the cannulated screws and the dorsal bridge. And this was because everyday activities like walking and standing for extended periods became extremely excruciating and painful, impacting his mental health so severely that he had requested for them to be removed. So this was a voluntary procedure and was agreed to by the orthopedic surgeons during his consultation. And he stated that post-operatively he did experience some relief in terms of the level of pain that he would encounter. However, it did not diminish it entirely. And he still encounters regular ongoing swelling and stiffness and pain every now and then, but not to the same degree as when he had the screws and dorsal plates installed within him. But also, as you can see from the x-rays that were taken post-operatively, 2 screws did break during the procedure and had to be left behind, the remnants anyway, due to being too difficult to retrieve. And this just highlights some of the complexities and challenges that are involved in some of these surgeries. So that brings us to the end, and to conclude, there are just some key things I do really want to emphasize on, and that is that timely surgical repair is so important in Lisfranc injuries because it is such a physically taxing condition to recover from and can lead to life-altering functional limitations. And improving access to specialist care is also just as equally important, and this doesn't just refer to foot specialists with knowledge or experience in dealing with Lisfranc repair, but also physiotherapists that can also support patients in optimizing their post-operative recovery. Thank you so much for listening.
Wonderful presentation. We are sad to unfortunately miss you. Judges, if you may go ahead and proceed with your submitting your response form. She's not here, so we unfortunately can't open it up for questions. We will now be displaying a QR code for audience voting as well. So please go ahead and scan the QR code on the screen to vote for your favorite presentation. Your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. So for our next presenter, I'm happy to introduce Ms. Jennifer Ebel-Gayton from Mexico, who will be introducing her original research entitled Publication Rate of Students and Graduates of the Program of Combined Studies in Medicine, PSEM, and MD-PhD Program of Mexico. Thank you.
Hello, everyone. My name is Jennifer Ebel-Gayton, and I'm currently completing my social services at the Faculty of Medicine of the National University of Mexico. And we are going to present our study titled Analysis of Publication Rate of Students and Graduates of the Program of Combined Studies in Medicine, an MD-PhD program of Mexico. We're going to see the introduction, the background, the methods, and the results of our study, and then our conclusions. Okay, so clinical scientists are really essential for bringing research and clinical that will bring really interesting information that will impact to the clinical care of the patient. However, in Latin America, these dual training are really rare, which contributes to the limited region publications. Scientific output in Latin America. But in 2011, UNAM established the program of Combined Studies in Medicine, which contributes to the scientific outputs in Latin America, and it's the first one MD-PhD program styles in Mexico. PSEM integrates medical research with intensive clinical attention for the undergraduate level. The main objective of our article was to analyze the productivity of PSEM students and graduates and to see the productivity trends, the most recent rich topics, and the academic impact over time. Then, by doing so, we aim to assess how this innovating program can impact to contribute to physics and scientists in Mexico. Then we perform a cross-sectional cyanometric analysis between 2030 and the first half of 2025. The data we're collecting using the Scopus database. We identified that at least one of the PSEM students was an alpha. For each publication, we extracted the year publication, the journal type, if it is national or international, the impact factor, the number of citations, and the research topics. In addition, we compiled all the data into a Microsoft Excel database, and a descriptive analysis were performed to determine the publication trends, the most frequent research topic fields, and overall impact. Between 2030 and 2025, PSEM students published 790 original articles. Of this, 91.8% were in international journals, and the other 5.2% were in national. 554 articles are from the graduates that are really a high percent of all the articles of the PSEM program. The second generation was the most productive of all the generations, with 30% of all the articles. The most frequent topics were endocrinology with 30.4%, then applied statics in medicine with 12.3%, and then oncology, infection disease, and epidemiology. The average impact factor was 4.26, and the mean number of citations was 17.9, and that indicates us that high visibility of the articles published by the program. Well, we can see here that in 2021, the PSM students and the productivity of the program notably increased after 2021. Maybe we can see that because of the COVID-19 pandemic on global research engagement. By 2025, PSM had 110 active students across 14 courts, including 30 graduates, 9 women and 21 men, who completed both degrees. This finding highlights PSM's programs is really important in Mexico because the contribution of the program to the scientific contribution and cultivating the next generation of the scientific the physical scientist generation in Latin America. Well, for conclusion, we can say that PSM program demonstrates that it is possible to integrate medical education to scientific training successfully in the undergraduate level. The result of the study show us that students not only capable of producing high quality research, but also to contribute to the international medical community. By fostering early research engagement, PSM helped narrow the gap we have in Latin America about the publication we have. And we are like, this program serves as a model for other institutions that are seeking to strengthen the role of physical scientists. I don't know if you have questions.
Thank you so much for your excellent presentation, Ms. Gayton. So now I will be opening the floor up to the judges for questions.
Okay, thank you very much. I want to commend Pletitor for good work done. My question is very simple. I want to understand why you chose only Scopus. Why did you restricted your work to Scopus? Why not other repository? That's my question.
Well, because it offers us biomedical coverage in Mexico and provides consistent citations and using one platform for sure is ensured the medicological consistency. So for us in Mexico, it's better Scopus to find that data.
All right.
Oh no, go ahead. Go ahead.
Yeah. My question is there any particular year in medical school where the students were publishing more frequently than other years? Was it just the first year or the first year of clinical rotation? From which year in medical school did you get most of the published articles?
Yeah, well, I'm in UNAM, in the National Autonomous University of Mexico. So my study was about the program we have in the Faculty of Medicine, that is PSM. So we have a lot of publications. The program have a lot of publication. And I think it's very important to see the we have strong institutional research lines and the presence of a lot of mentors with the areas we have, like endocrinology or oncology, that was the most published research topics we have in the program. I don't know if I answered the question or if it...
Yeah, I'm satisfied with the answer. Satisfactory.
Thank you.
Thank you, Dr. Adini and Dr. Nini. Dr. Ode, did you have any questions?
Thank you for your brilliant presentation. Please, I just wish to ask if there were challenges faced in initiating this program, major challenges, just to find out.
Yeah, well, we have a lot of it's a new program because it was standard in 2011, so the program had a lot of things going on, but it's important to see that there are a lot of graduates, and the graduates are generating a lot of publications. So I think it's working, and when the program see that something is wrong, they quickly respond to that issue to respond to the needs of the students of the programs.
Okay, thank you.
Thank you so much, judges, for the questions, and Dr. Gayton for also answering them. So judges, please do use this transition time to submit your judging response form. As for the audiences, we will now be displaying a QR code for audience voting. Please go ahead and scan the QR code to vote for your favorite presentation. Your votes will help determine the awards that we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you so much. All right, so we will be moving on to our final presenter, Mr. Kyle Thurman from the United States, who will be presenting an original research entitled National Trends Reveal Hypertension as the Dominant Driver of Cardiovascular Readmissions. Unfortunately, Kyle was unable to join us today, so we will be watching his video instead. Thank you.
Hi, everyone. My name is Kyle Thurman, and I am a medical student at Creighton University in Phoenix, Arizona, in the United States. Today, I will be presenting a nationwide analysis examining cardiovascular specific readmissions after heart failure hospitalization with a focus on hypertension as a leading driver. Thank you for being here today, and I hope you are enjoying the International Journal of Medical Students Conference. All right, so for some background, heart failure is one of the costliest cardiovascular conditions, and readmissions drive the majority of this expense. Most literature focuses on all-cause readmissions, which obscures specific cardiovascular drivers. Hypertension is a well-established cause of heart failure, yet its role in recurrent readmission patterns after discharge is not well defined. Emerging data suggests that many heart failure patients continue to struggle with blood pressure control after hospitalization, but prior studies have not quantified how frequently hypertension itself leads to subsequent cardiovascular admissions. Thus, our study addresses this gap by identifying the leading cardiovascular diagnosis associated with readmission following a heart failure hospitalization. So to put the cost into perspective, by 2030, heart failure hospitalization cost is projected to be $69.8 billion. This is a very steep value. All right. Our aim, to be specific, was to determine which cardiovascular diagnosis most frequently accounts for readmissions after heart failure discharge. We hypothesize that hypertension plays a dominant role in the readmissions of patients after heart failure. Okay, so we conducted a retrospective cohort analysis using the nationwide readmissions database. So this database spans from 2016 to 2022, and it captures over 60% of US inpatient hospitalizations. We included adults hospitalized with a primary diagnosis of heart failure and tracked cardiovascular specific readmissions at both 30 days and 1 year. We categorized readmissions by diagnosis with hypertension and hypertensive crisis compared against other major cardiovascular causes. These other causes include recurrent heart failure, arrhythmias, myocardial infarction, stroke, and thromboembolic disease. Survey-weighted chi-squared methods were applied to generate nationally representative estimates and calculate relative risk for each diagnostic category. The significance threshold was set at less than 0.001. Okay, so for our results, our demographic results, we included nearly 32 million weighted heart failure hospitalizations. These 32 million hospitalizations represent a medically complex, high burden, and predominantly older population. The majority of patients were insured through Medicare and received care at large urban teaching hospitals. This underscores both the real-world equity of heart failure admissions and the substantial resource demands placed on tertiary care systems. Importantly, 75% of these individuals had a comorbidity index of greater than or equal to 3, which indicates a significant comorbidity burden in this population. Okay, for our primary results, hypertension or hypertensive crisis emerged as the dominant cardiovascular cause of readmission at both 30 days and 1 year, accounting for roughly 2/3 of all events. Across every comparison group, relative risk ratios showed substantially higher readmission rates for hypertension, and large effect sizes confirmed a strong and consistent association, emphasizing that hypertension disproportionately drives post-discharge cardiovascular utilization in heart failure patients. So we can see when comparing heart failure or hypertension with all the other cardiovascular diagnoses at readmission, hypertension led 5 times higher when compared to heart failure readmissions, 7 times when compared with arrhythmias, 10 times versus MI, 10 times for stroke, and 75 times for venous thromboembolism. The effect sizes were very large, 0.53 to 0.69. Okay, interpretation and clinical importance. These results highlight hypertension as an overlooked but highly modifiable driver of recurrent cardiovascular hospitalizations. Improving blood pressure control after heart failure discharge may meaningfully reduce preventable readmissions. Targeted strategies, which include aggressive outpatient blood pressure titration, early post-discharge follow-up, and remote blood pressure monitoring, represent actionable pathways to curb rehospitalizations and improve long-term outcomes in this high-risk heart failure population. Okay, in conclusion, hypertension overwhelmingly drives cardiovascular readmissions after heart failure hospitalization. This far exceeded all other cardiovascular diagnoses. Prioritizing targeted interventions and structured transitional blood pressure management is critical to reducing preventable rehospitalizations and improving patient outcomes, particularly in the vulnerable early post-discharge period when risk is highest.
Thank you so much, Mr. Thurman, for the presentation. We are sad to have missed you today. So judges, please go ahead and proceed with your judging response form for Mr. Thurman's presentation. And we will now be displaying a QR code for audience voting as well.
Okay.
So please go ahead and scan the QR code on the screen to vote for your favorite presentation. Again, your votes will help determine the awards we will announce during tomorrow's ceremony, so please don't forget to participate. Thank you. Thank you so much, judges and presenters, for all of your wonderful presentations today and questions. It has been truly inspiring to witness medical students from around the world share their research, your courage to ask important questions, challenge the status quo, and dedicate time to scholarly work, often while juggling the demands of medical school, is truly remarkable. Today's sessions showcased not only scientific rigor, but also the creativity, resilience, and global unity that define the next generation of physicians and medical researchers. It has been a privilege to see your ideas come to life and to learn from the diverse perspectives each of you bring to the field of medicine. Please join us tomorrow at 8 a.m. Eastern Time as we will continue another exciting round of oral presentations in the morning, followed by our 2 poster sessions in the afternoon, and finally our awards ceremony. As for the awards ceremony, please be sure to join us around 1:45 p.m. Eastern Time so that we can announce the award recipients from both today and tomorrow's presentations, and to celebrate the culmination of your hard work. Thank you again for such an incredible first day. We look forward to seeing you all tomorrow. Bye.